That's a tough task. Okay. Right, that's always joke. Who's the boss of you? Nobody. All right. Welcome everybody to the 2022 intern presentations. This is such an exciting time. This is transitions are always exciting and anxiety provoking. This is for those of you who are leaving. I think what you'll find is just take a look back and think about how you were at the beginning of the year. Or for those of you who were here 2 years, think about where you were last year and think about where you were the year before that and all that you've learned. And the level of competence that you've achieved. And it's really remarkable what can happen in a year. It's amazing, right? Of course, then you have to sort of start all over in your next position at school, grad school, whatever it might be. Life is a series of achieving competence and going to the bottom and being at the bottom of the barrel and getting to a certain point and starting again. But hopefully the trajectory is always up. And the point of this is it's good to get comfortable with not knowing stuff, because the antidote for not knowing stuff is learning stuff. And your life should always be about lifelong learning. And opposed to the old medical model where you kind of fill up the tank and then you go out and practice, the idea is, I hope what you've learned over this year is the goal of medicine is continuous learning. That is the model for what we do. You think you've got a good idea, you do things, but you always must assess. You always must ask yourself, is this right? Or can it be done better? Can I do it with less toxicity? Can I do it with more precision? Do I even need to do this? And not to be afraid to challenge the status quo. Remember, my first book is going to be The Tyranny of the Status Quo. Anyway, or maybe Overturning the Tyranny of the Status Quo, or something like that. Since I wasn't allowed to do my TED Talk. Anyway, I was resoundingly vetoed by the TED committee. Anyway, great title, don't you think? Anyway, so that transition is both wonderful. We're so proud to see what you've achieved and who you've become. It's really, that's what we're here for. All of us who are mentors in the program, this is our most important job. Our most important job is making sure that we invest in the future of medicine. And we know all of you are going to be future leaders. You're going to come back to our Sparking Innovation program, which will resume post-COVID this summer. And we're going to see what people are up to. It's very exciting. We'll figure out how to do that. So it's really quite wonderful. And I especially want to thank all the people who have taken the time to help all of you, not the least of which is Anne-Marie. Because without all of the mentors, you would not be where you are. And it is, one of the most important things we can do in our lives is to help others to become the best that they can be. So you're going to hear about all these presentations. Those of you who are starting, you will be amazed. How did these guys know all this? But this will be you next year. So that's important. And that's what we expect. We know you can achieve it. That's what we expect, and you will rise to the occasion, I am sure. And so you've got some big shoes to fill, but the only way to fill them is to step right in. So we wouldn't have picked you if we didn't think you could do it. So as we go through these presentations, don't forget, everybody has to start with the most important lesson that I learned this year is. And so that is the surprise for me, since I do kind of know what everyone's presentation is at this point. But we are very excited to start. So without further ado, I think Evan is our first presenter.
Okay. Hi, everyone. My name is Evan. And Laura kind of already touched a bit on one of the most important things I learned. But I think I learned especially from Laura is that we shouldn't be afraid to challenge the rules and the way things are, especially when it comes to prioritizing patient care, that sometimes it's okay to break the rules, and sometimes you need to, and sometimes we have to change the rules, and that's how we make things better. So. Okay, so today I'm going to kick things off, and I'm going to talk a little bit about my project, investigating attitudes towards treatment de-escalation in the I-SPY 2 trial. So before I begin, I want to take a few minutes and talk to you guys about the I-SPY trial. You'll hear a lot from our colleagues today, this afternoon, about I-SPY, so I just want to give a bit of context. So I-SPY 2 is a phase 2 investigational drug trial for patients with early stage high-risk breast cancer. Patients are randomized to one of a number of different neoadjuvant treatments based on their unique biological characteristics. And so using a process called adaptive randomization, patients that go on I-SPY have a higher likelihood of receiving a drug that has the greatest chance of reducing or eliminating their tumor, because the trial is continually learning from previous patients that have gone on. So traditionally, over the course of the trial, all patients would receive 2 types of chemotherapy. They would start off being randomized to an initial arm and then followed by a second drug regimen called AC. And AC is a chemotherapy regimen that is often harder for patients to tolerate, and has been associated with more toxicities. After all of their treatment is finished, patients would then proceed to surgery, where they're evaluated for whether there is any remaining disease. The goal of the trial is to use these novel investigational drugs to minimize the amount of disease left over after treatment or residual cancer burden, because this is predictive of long-term outcomes. And so recently, the trial has introduced an alternate route to surgery, where patients can skip the toxic AC regimen if there's an indication that there is no disease left after the first phase of treatment. This is based on MRI and biopsy and pathology results. So after the first 12 weeks, patients have an MRI and they have a biopsy. And if both show evidence that the patient has reached a complete response, they're then given the opportunity to proceed directly to surgery. And so we know that this is a safe option because based on results from a large-scale meta-analysis of data from over 27,000 participants, which demonstrated that achieving a PCR or a pathological complete response, meaning that all the cancer has been gone, this was strongly predictive of outcomes as measured by event-free survival. And so as you can see in the graph on the left, both patients that received adjuvant chemotherapy after achieving a PCR and patients that didn't receive additional chemotherapy after achieving a PCR, their long-term outcomes were essentially the same. And so additional therapy adds no significant benefit to patients. And so since we do have tools to help predict whether patients have reached a PCR, we can offer them ways to spare unnecessary toxicity and allow them to skip AC and go to surgery. And so while we know this, and it's really exciting, previous studies have also shown that patients are hesitant to do anything less than standard of care. And so based on this, additional research is kind of needed to understand how patients are thinking about de-escalation and how are they making these decisions. In my role as a coordinator for the I-SPY trial, I have been able to kind of see patients as they reach this time point and as they make these decisions. And I've seen that patients in real time, the many different things that they're considering when making decisions for treatment de-escalation. And so we really wanted to explore this a little bit more. And so I created a project to assess this. And so the goal of this study is to understand both the facilitators and the barriers for patients and their providers in pursuing a de-escalation pathway. So we know that when making treatment decisions, this is often a joint decision, both with patients as well as their doctors. So we really wanted to understand how patients are considering this decision, as well as how their doctors are thinking about making this decision and how they advise their patients. And so the study design, what we are doing is we are conducting qualitative interviews with I-SPY patients across all sites across the country, as well as their study physicians. And so we have 2 cohorts, a prospective cohort, as well as a retrospective cohort. And so in the prospective cohort, we are actually interviewing patients both before, during, and after they make any de-escalation decisions. And then in our retrospective cohort, we are interviewing patients who have already kind of made this decision and then just capturing their reflections. So today I want to share a few insights that we've gleaned from 2 different patients in our retrospective cohort that went through this process here at UCSF. So our first patient, this was a young woman who, when describing her initial expectations for treatment, she said that AC was always the scariest part of treatment for her. When making the decision on whether or not to skip AC, she had to balance both her personal priorities as well as some fears of reoccurrence. She said that the two biggest things that she cared about protecting were her fertility and her hair, and she knew that AC would affect both of those more drastically than the first treatment regimen that she was on. And she also, in terms of motivations for wanting to skip AC, even the idea of just a sense of relief and getting 2 months of her life back and not having to endure additional treatment. However, she did have concerns and fears regarding recurrence. She said she was concerned about the combination of not doing AC as well as electing to do a lumpectomy, and she felt that it was almost like she was doing the bare minimum. And she said that if the cancer came back, she was going to blame herself for not doing everything she could. However, in the line, again, of this being a shared decision, this patient also expressed that while it was scary for her initially to decide not to do AC, she said that she needed to hear from her study doctor that it was okay to do this. And this gave her the comfort that she needed to move forward in this decision. And another patient I spoke to, this was a slightly older patient, and she was motivated to participate in I-SPY, particularly because of this option to de-escalate. She expressed that if there were a chance that she could beat her cancer without having to endure the harsher side effects of treatment, she wanted the opportunity to take that chance. For this patient, she said from the beginning, she'd kind of internalized her understanding of AC as something that was harsh and evil. She said as a single woman living alone and working from home, she needed to be able to provide for herself and take care of herself on a day-to-day basis. And she just did not see herself being able to achieve this while undergoing AC. And so she was extremely motivated from the beginning and was very relieved when she had the opportunity to take that alternate path to surgery. And again, this patient was also comforted by her study doctors in making this decision, describing that she felt extremely happy being part of a team that was also so excited for her to have this opportunity. And so even in these two short examples from two different patients, we can see that there are clearly very diverse perspectives, that patients all have their own unique motivations and concerns when making these decisions, and that de-escalation may be attractive, but it's not necessarily a given for all patients. And then we also can see that physician attitudes do have an impact on patient decision-making. And so what we're going to continue to do with this project is continue to gather more information from both patients as well as their providers. And once we have reached our full cohort, parsing the data and really identifying key themes and patterns, and using that to create educational opportunities. So letting patients know why this is a safe option, making sure that they are aware of what potential outcomes can be, of what the options are for them, and making sure that both patients and their providers have the information that they need to make informed decisions. And all of this we will use as well with I-SPY 2.2, which you will be hearing a little bit more about, which will inform both escalation and de-escalation processes. You'll hear more about I-SPY 2.2 from Teddy later on, but just a quick glimpse, you'll see that in the nature of an adaptive trial, we want to take what we've learned from patients and their experiences and apply that information to this new trial design, where you can see there are multiple opportunities for patients to bypass additional therapy and go straight to surgery. I would like to say thank you to all of my mentors and everyone that has helped me work on this project. I really appreciate everyone's help.
Right, well, that was fantastic. Very complex topic in a very succinct fashion. Just out of curiosity, who do you think is more concerned about side effects, physicians or patients?
Patients.
Patients,
yeah.
And that's how I know this trial is going to succeed, because it's about patients, and this choice is about patients. And honestly, this design was motivated by my coming to the room and saying to someone, oh, your tumor looks like your tumor's gone away. This is between taxon and the AC portion. Oh, great. You mean I don't have to have the AC? Like, well, no. He goes, well, why do I have to have the AC? And that's a very hard question. So I'm like, because we always do it. Which of course, as all of you will come to know, is not a good answer, right?
Right.
Okay,
Change the
one
rules.
last question for you. And Anne-Marie, you can monitor the chat. I mean, the questions on the chat, but I think another thing that you experienced in this particular project of simply asking questions,
Yes,
that's not necessarily so easy.
it is not.
And there are always barriers. And what do you have to do when those barriers show up?
You keep going and you change the rules to make things happen for you.
Or find someone who has a different view of the rules, which was
There you
our
go.
IRB chair, and so we fixed it, right? So it's like no is not the answer.
Right.
No is just the opening salvo. So that's just like that. Okay, any other questions? Yes, Karen.
Thank you.
You don't know.
The question was, what percentage of women actually choose to de-escalate?
Of the people who are eligible,
Of the people who are eligible.
the majority actually. So some are, I mean, some are in the 60 to 70.
I think so.
Yeah.
I
Yeah,
can
we're-
get those
I'm-
numbers for
I'm-
you.
I'm going. That's someone who has a complete response.
Yeah, the question was, do we see an association with age or any like profile? And that's something that we're actually collecting. We're getting like demographic data as well from these interviews. So hoping to see if, that also influences some of these decisions.
We
So,
can
yeah.
work on that next year.
Yes.
Yeah, I aspire, she's going to actually the institution where her mentor is, so it's perfect.
We have one question from the chat. It says, it's from Laura. Does iSpy include questionnaires or surveys to ask about patients who decline to enroll into iSpy treatment?
Yes, because we're having a real world cohort, so yeah. For people who choose not to go into it. Okay. I also want to acknowledge Amy Babel, who is on the line. I'm so excited, Amy, that you are here to witness all these presentations. Again, Amy and her family have actually endowed this internship that allows us to have Anne-Marie manage all of you guys. And just so you know, Amy, we've grown to 15 interns. So anyway.
It's always exciting to see these amazing people, interns, do this incredible work. So it's a pleasure. And congratulations to everyone.
Thank you so much. All right, so we're sticking with the iSpy theme. And people at high risk for breast cancer, we're going to move right on to Yulissa.
Hi, everyone. My name is Julissa, and before I begin, the most important thing I learned this year was to not be afraid to take initiative, whether that's to reach out to someone first or start on a project that you're interested in. Today, I will present on the iSpy endocrine optimization pilot, or EOP, and the preliminary findings in the MRI volume and FBS uptake in the UCSF cohort. But before I speak about these findings, I will give a brief background and overview about breast cancer and the EOP trial. So the majority of patients that present with stage 2 breast cancer have molecularly high-risk tumors based on their mammogram score, and we know that they can benefit from chemotherapy in reducing their recurrence risk, which often happens within the first 5 years. However, there are molecularly low-risk tumors and hormone receptor positive tumors that have little benefit from chemotherapy, but they do have significant late recurrence, which often happens after 5 years. This brings up the importance of needing to find better treatment for these patients since they do not benefit from chemotherapy. And the neoadjuvant setting offers a unique opportunity to study these new treatments and specifically endocrine treatment. As Evan mentioned, the I-SPY trial is a new adjuvant trial where we are studying new chemotherapy agents for patients with invasive breast cancer. When patients screen for the trial, we further determine their eligibility by their mammogram score and estrogen receptor, progesterone receptor, and HER2. And most patients continue screening for the I-SPY chemotherapy trial because they are molecularly high risk and therefore would benefit from chemotherapy. But about 15% of screening patients are not eligible because they are mammogram low risk, hormone receptor positive. These patients are instead eligible for the new endocrine optimization pilot trial, or EOP. And recently, the EOP trial also includes patients with mammogram high risk if the patient has no node involvement. The goal of the EOP trial is to make endocrine treatment better for these patients that have little benefit from chemotherapy in the long run. In the EOP trial, eligible patients undergo a 1:1:1 randomization. All arms consist of the same backbone drug, which is amsenestrin. And in the first arm, amsenestrin is given alone. In the second arm, amsenestrin is combined with letrozole. And in the third arm, amsenestrin is combined with abemaciclib. Amsenestrin is a selective estrogen receptor degrader, or SERD. And as the name implies, it degrades the estrogen receptors present in hormone receptor positive tumors. Letrozole is an aromatase inhibitor that blocks the estrogen production in the body's normal tissues. And lastly, abemaciclib is a CDK4/6 inhibitor, which the name implies, it inhibits these proteins called cyclin-dependent kinase 4 and 6. Regardless of which arm a patient is randomized to, they do receive treatment for 6 months and then they proceed to surgery. And during the study, patients will have multiple MRI, blood samples, biopsies, and NAMI PETs at different time points, including before treatment, at 3 weeks, at 12 weeks, and before surgery. The primary objective of EOP is to investigate the feasibility of enrolling and treating patients with early stage hormone receptor positive breast cancer. And feasibility will be determined if at least 75% of enrolled patients complete at least 75% of study therapy. Secondary objectives include identifying biomarkers that can be used to assess response to neoadjuvant endocrine therapy, such as the MRIs and the NAMI PET. So as my title of the presentation, I will focus on the NAMI PET and MRI scans and the findings we have so far. And as I mentioned, patients do have multiple of these scans throughout the EOP trial. And the goal of imaging is to try to find out early on which tumors are responding to treatment, which need more or less treatment, and which need a different approach. In a NAMI PET scan, we use fluoroestradiol, which is a modified version of estradiol, a form of estrogen. And this allows us to use FES for PET imaging of estrogen receptor tumors. And FES has been found to predict the likelihood of response to endocrine therapy. Below, you can see some images that show what the NAMI PET scan looks like, how a patient would lay down, and where the breast would be inserted. For the MRIs, we use gadolinium, which is a contrast agent to allow us to view the cancer and internal body structures. In the left MRI image in the panel A, you can see that it's very difficult to view the cancer without gadolinium. But in the panel B, we notice the cancer is easier to see after gadolinium is given. And below, we have a few images of what the MRI looks like, how a patient would lay down, and where the breast would be inserted as well. The rest of my slides will focus on the 10 patients at UCSF that have completed treatment and gone to surgery. 5 of those patients were in the 40 to 49 age range. 6 patients were premenopausal. 7 patients had a grade 2 tumor, and 6 patients had a tumor size of 2, which is greater than 2 centimeters and less than 5 centimeters based on the MRI scan. And 5 patients had the ductal carcinoma. And in terms of the mammogram score, 6 patients were low risk. In this graph, I'm showing the functional tumor volume that was calculated based on the MRI images. On the y-axis is the MRI functional tumor volume at different time points relative to that tumor volume at baseline. And on the x-axis is the time from the treatment start in weeks, so from 0 to 24 weeks. Each line does represent a patient, And we are plotting how their tumor volume changes throughout the second MRI, the third MRI, and the fourth MRI. As you can see, there is a wide variation of response in the tumor volume. Some patients had a bigger drop in their tumor volume, others had a modest drop, and some of them did not have much of a difference. Here's an example of one of our patients. Inside the red box, you will see the tumor and the functional tumor volume is below it. You can see that the tumor is getting smaller throughout treatment, and the FDV volume is also decreasing. So for example, if you look at the red box in the pre-treatment, it appears to be a little bit bigger compared to the pre-surgery image. And this patient started with a baseline tumor volume of 2.128 centimeters cubed, and then it decreased to a 0.282 centimeters cubed before they went to surgery. Here I am showing the MAMI-PET results, specifically the SUV max at baseline, 3 weeks, and before surgery. SUV max is the maximum uptake of the FES tracer that we are using for these scans. About half of these patients had a detectable tumor at 3 weeks, but half of them did not, compared to everyone having a detectable tumor at baseline. And when patients had their pre-surgery MAMI-PET, only 2 patients had a detectable tumor with an uptake of FES. Here I'm also showing again the same patient and the MRI images, but I am also showing the MAMI-PET scan below. You can see that this patient started with a SUV max of 8.18 before treatment, and then at 3 weeks, they had an SUV max of 5.66. And then before surgery, their tumor was not detectable. The black and white images are the images we actually get from the MAMI-PET scan, and then we process it to color to be able to calculate that SUV max using the color spectrum. And as you can see, both the MRI and the MAMI-PET are great imaging tools that are useful to image which tumors are responding to the treatment that patients are receiving. This was just a glimpse of our preliminary results for our first 10 patients at UCSF. There's a lot more we still need to do, but our next steps would be to sample a larger patient population at UCSF. It would also be interesting to include UCSD patients who are also receiving MAMI-PET scans and MRI scans. And then lastly, it would be interesting to explore the change in the MRI background parenchymal enhancement to really see if the tumor volume that we are measuring is in fact just a tumor or the background noise. I really want to say thank you to everyone that I have worked with for the past 2 years. It has been an amazing time, and I really appreciate the advice and knowledge that I've received from every single one of you.
So this, I particularly want to commend you on making this from very technical and incomprehensible a couple of weeks ago to something very accessible. Most people understand. I mean, I know other people weren't exactly, but I think it was very understandable. And importantly, we actually have to come up with what we're going to do next. And so one of the problems we have is that, you know, unlike complete response, which we use as our endpoint, that's probably not the right endpoint here. And part of that reason is the timing of recurrence. When do most of these people with it's not that the lower molecular people have no risk of recurrence with all that disease, right?
Right.
But what's the timing of the recurrence? When does that happen?
It often happens after 5 years, so it has a late recurrence risk.
That's right. So it's late. And the problem is by the time you get there, it's too late. Someone shows up with metastatic disease, now they've got incurable disease. The question is, how do you know? How do you know? Oops. So how would you know early on whether they need anything else or not? That's the question. So I'm putting this slide back up because I look at that and that gives me an idea. Does it give you an idea?
How do we know?
Do you know what I mean, we don't know what people have.
Right.
But, you know, especially, let's just say that there's a different, like, are there some people who have, when do you think you get a sense of what the response is?
Early on, that's why we use different imaging techniques to be able to see if they are responding or not early on. So for the second MRI, that's when we tend to see the biggest change, whether it's a bigger drop or a less drop. And then from the third MRI to the fourth MRI, there's really not much change compared to the second MRI. Yep.
Yeah, Laura, one of the things that really was interesting in this initial data is look at the drop at 3 weeks, right? You've got a number of patients that drop significantly at 3 weeks, which is very strange for hormone therapy. And we had, Natsuko go back and just make sure that they were measuring it correctly, and at least using the methods that they used for the main trial, it looks real. So I don't know if this is an issue of, needing to, measure it differently with hormone therapy. But there's something interesting about this group that drops so greatly so early.
Yeah, but that's it. I just emailed you, but that's. But the thing is,
I'm by the pool at swim practice, but I'm here.
well, forget the swim practice. We got to start writing the next version of the trial. So anyway, but we have to have an endpoint, right? And that endpoint, I mean, what if, I don't know who these people are, but these people are cert alone. I bet the people with an early drop, these are early responders. That's good enough. That's what we're looking for. We're looking for a hypothesis that we're willing to test. What I love about this is the dynamic range. The PET might also have it. You get half have a good response and half don't. If everyone has a good response or no one has a good response, that's not a good biomarker because there's no dynamic range. Dynamic meaning change and range. Like, is it a hypothesis worth testing that if you have a really good early response, that's good enough? You don't need to add a bunch of stuff? Probably, because a bunch of people do well. So that you would only you do that 3 months or 6 weeks, or when are we doing the second? We do it 3 weeks,
3
and
weeks, 12 weeks.
and 12 weeks. Yeah, 12 weeks. Then randomize to something else. That's what I think we should do.
But think about,
Hey, you also think so too. That's it. We're doing it. But
I know, but think about what we would expect with hormone therapy at 3 weeks. I mean, nothing, right? So this is really surprising to me. I mean, it's very interesting to see that much drop with 3 weeks of hormone therapy.
it is not to me because I've been doing this in active surveillance in BCIS. You see the changes.
But then, but also not only, like, you don't get for that bottom group, you're not getting much additional response for the remaining like 5.5 months.
Yeah, so we can do it in 6 weeks. I'll argue about it, but in early response, I'm just saying early response. So everybody gets the backbone alone for 3 to 6 weeks, 6 weeks. And then leave them and then take the people without a great response and start adding based on something. Yes, Ananya.
I was wondering, did you look at whether the patients that had that really steep decline correlated with any of those factors that you showed in the previous slide? Like, were they all younger? Were they all higher risk? Or more disease?
No, we did not get to that.
We don't know, but we have 70 patients we can look at. This gives us an idea. So now we know where to go. Good job, Yulissa.
Thank you.
Oh, yes, right. One more question.
We also have a question in the chat, and they're asking if there's a difference in the SUV trained with different medications.
We also have not got to that. I personally know which patients had which treatment, but the person that was analyzing the data did not. So
Okay, well, you tell me.
yeah.
Yeah, I mean, this is why we do these preliminary data. We're looking to get the idea for how to design the next version of this. The amazing thing too is that the accrual is much faster than we thought, which shows like, and have you had trouble getting people to agree to this trial?
No.
Huge demand. Again, very patient centered. People are super excited about it. And a lot of these people, So I would say the standard is not because chemotherapy works, but people feel bad, so they didn't do it. So that is not a good reason to do it. All right, fantastic job.
Great job, Julissa.
All right. Staying with I Spy and all the progress that we're making, because we never want to stand still. That would just be terrible. Yes, okay, got it.
Okay, my name is Teddy, and the most important thing I learned this year is to advocate and push for the projects you're passionate about, because in the craziness that is the BCC, sometimes things can get overlooked or pushed to the bottom of the priority list. So if there is something that you're really interested in, sometimes the best thing you can do is just be the person constantly pushing for it to happen, even if that means resending an email a few more times than you may like. And today I'll be talking about the new response predictive subtypes as part of I-SPY 2.2. So as we all know, breast cancer is not just one disease, it is heterogeneous. And to tackle this diversity, we use subtypes to group patients in informative ways. For example, the receptor subtypes have been used historically for decades now, classifying patients into one of 4 subtypes based on immunohistochemistry, or IHC, expression of HR, hormone receptors, and HER2 receptors. And these subtypes are useful to us because they help clinicians target drugs to patients most likely to respond to them. For example, we know that hormonal therapy can be effective for HR positive patients. And similarly, HER2 targeted therapy can be effective for HER2 positive patients. However, as research has progressed, we've developed new classes of agents such as immunotherapy and DNA damaging platinum agents. And now our receptor subtypes don't go far enough to help us identify potential responders to these new types of drugs. And so for I-SPY 2.2, we sought to fill in these gaps by creating a new subtyping schema that incorporates additional biomarkers predicting response to these new classes of agents. You can see here that we've retained HR and HER2 status, but we've also added in 3 molecular signatures, one for immune sensitivity, one that detects DNA repair deficiencies, and one that classifies patients into one of 3 molecular subtypes, which you'll hear more about from Jae-yoon shortly. And classifying by these biomarkers creates 48 possible subtypes, which we then simplified down into these 5 response predictive subtypes you see on the right. I'll be referring to these as DRD positive, immune positive, DRD negative, immune positive, DRD positive, HER2 basal, and luminal. So you can see from the Sankey plot here that we have the receptor subtypes on the left, and they are split into different response predictive subtypes on the right, based on the type of drug that each patient is most likely to respond to, specifically these classes of agents. And as you'll see again soon, some of these subtypes still lack effective treatment options, hence the question marks you see in some places here. So as we implement these subtypes in I-SPY 2.2, which had been discussed briefly earlier, one of our goals will be to find better therapies for these groups as part of our continued push to further personalize breast cancer management. Now, as a bit of background, the way that we evaluate response to chemotherapy is by quantifying residual disease after chemo using a metric known as residual cancer burden, or RCB. You may have heard that mentioned already today. On the left, you see some of the components that go into the RCB calculation. And in general, lower levels of residual disease, aka a better response, is correlated with better survival. RCB is calculated first as a continuous index from 0 to 5, and then is grouped into a categorical variable based on established cutoffs to create the classes, the RCB classes 0 to 3. Of course, RCB 0 is equivalent to a pathologic complete response, or PCR, which is what we strive for and serves as the primary endpoint for I-SPY. And the RCB classes 1, 2, and 3 correspond to mild, moderate, and severe residual disease. So because we're beginning to use these subtypes in clinical practice, we need to ask, for each response predictive subtype, can we use response to therapy as measured by residual cancer burden to predict survival? And secondly, how does each of these subtypes respond to chemotherapy differently? So to answer these questions, I took data from I-SPY, meaning patients at high risk for recurrence, as you've heard, and they had the following distribution of response predictive subtypes. And now we'll take a closer look at RCB and survival in each of these subtypes. So these are Kaplan-Meier curves showing survival over time. On the left, we have the DRD negative subtype, and on the right, immune positive. Each of these is broken down into the 4 RCB classes, from RCB 0 in blue to RCB 3 in red. And as we would expect, residual disease is associated with decreased survival in both of these subtypes. And we also see a clustering of RCB 0 and 1, meaning minimal residual disease, compared with RCB 2 and 3, or larger amounts of residual disease. Moving to the next 2 subtypes, we have DRD positive on the left and the HER2 or basal type on the right. And here we see a similar pattern where higher RCB classes experience a higher rate of events, and we also see a bit of clustering here as well. So altogether, we see that RCB can be used to stratify patients into groups with different risk of recurrence for these 4 subtypes shown so far, which comprise about 94% of I-SPY patients. However, the luminal subtype seems to have a somewhat different pattern. We see that the 4 RCB classes don't seem to predict survival very well, besides maybe a slight increase in events for the RCB3 group in red. It has to be noted, though, that this is the smallest subtype, and so the sample size is quite small, so we can't really tell much from these data yet. Additionally, about 25% of patients in this subtype are molecularly low risk, which may further obscure any relationship between RCB and survival here. This is a relative event rate plot, and it's basically just another way of visualizing everything we've seen so far, with risk of events relative to RCB 0 on the y-axis and RCB as a continuous variable on the x this time. And here we can see things a little differently. For these 3 subtypes in blue, green, and yellow, the risk of recurrence increases fairly steadily as RCB index increases. But then for the DRD negative group in red, the RCB classes 1 and 2 don't have that much higher risk of recurrence than RCB 0, but then the risk really takes off as you get into RCB 3. And for the luminal group at the bottom, there is basically no increase in events across the range of RCB values, which is consistent with what we saw in the Kaplan-Meier curve just a second ago. So now we've seen that we can use RCB to evaluate which patients are responding well to therapy and will therefore go on to better long-term outcomes. And this density plot shows the RCB values that patients are getting in I-SPY broken down by response predictive subtype. For the middle 3 subtypes, we can see a large proportion of patients are achieving PCR or RCB1, which is great. However, the DRD negative group in red at the top and the luminal group in purple have very few PCRs, and a lot more of the patient population is falling in the RCB2 and 3 groups. And this is concerning because, as we've seen, residual disease is strongly associated with how long a patient can live without recurrence. So these high RCB values indicate that patients are not responding well to therapy, and therefore the risk of recurrence is much higher. You may remember from one of my first slides I showed that these are the same subtypes for which we don't currently have great treatment options, and this high levels of residual disease is a direct reflection of that. So conclusions are that RCB is a good predictor of survival for most people, except maybe for the small number of patients in the luminal subtype, but we do have more work to do to know that for sure. Secondly, patients in the DRD negative and luminal groups have unmet needs with lack of treatment options, high levels of residual disease, and correspondingly worse survival outcomes. So the mission here is really to enroll patients and explore promising new drugs through I-SPY 2.2 so we can directly target these disparities and move toward a future where we have the tools to fight every type of breast cancer. So quickly, I'd like to thank everybody who has helped and mentored me along the way, including all the amazing people who are not listed here. I'd also like to thank my fellow interns for making this a really fun and fulfilling year at the BCC. So thank you all.
Amazing job making something very complicated seem very simple. Have you actually tried plotting? Have you actually, even though it's a very small subset, have you actually looked at taking those, that quarter of the patients with the low risk out of the figure? Have you done that yet?
Yes, we have actually. I'll say we started with a very small sample size, and now we've made the sample size
I
even
know.
smaller. So it is hard to tell any conclusions, but it is trending in the direction of significance. So I think that as we accrue more patients, it could
Enough for me to
become
get a latte from Christina.
I
maybe.
don't know. This one is.
Oh, no, I want to see it before you declare I don't get my latte. You still owe me another one. All right. All right, so I think that you can see that you're gonna see, again, what is really nice about all these presentations is that each one of these is a piece of the important bigger program. And programs, I think one of the things that you all need to remember is that to do big things and to do great things, you need each other. And that you know, you've been taught to get to this point in your life that it's all about you and your MCAT scores and your grades. But I hope you know that that is not really true. And that it really is about creating effective teams and not only getting them to answer your email, but to join your project.
Exactly.
And your job is to have something you're passionate about and bring people in to work on your projects with you. And to do that, you have to share credit and you have to share the excitement, and life is just much more fun that way.
That's true.
Do we have any questions from the chat? Okay,
Thank
all
you.
right. See, and this is how we change minds and hearts and say, gee, it is time for new ways of classifying tumors, and gee, isn't it more fun to do things in a new way? Same old thing. Very compelling. Oh, yes,
Thank you.
Jill.
Sure. Sure. So the question is about for the luminal group, considering set index, should we be considering hormonal therapy for these patients? I haven't actually analyzed set index yet, but I think the data is trending towards yes. Sure.
So that's a nice thing about I-SPY 2.2, right? Because you can, right, so that we can, if they don't respond to something in block A. So first of all, anyone that are highly sensitive to endocrine therapy, and that's only going to be the luminal Bs. That's going to be those people that don't respond. But this still allows it, so they can either start on EOP or they can go into this. This still allows us to take the novel therapeutics that don't include classic chemo. But then if they don't, then we can try, you know, we're struggling a little bit. Our big CDK2/4/6 inhibitor, which we're going to put in a week, is currently on hold. But I'm sure one door closes and another one opens. That's it. All right, thank you. And while we're on the subject of luminal B tumors, those are these ones you just learned about. Damon's going to tell us a little bit more about that. Yeah.
Hi everyone, my name is Jane Yoon. And the most important thing I learned this year is that I cannot do everything, but I can do anything. And then the converse, I can do anything, but not everything. And that's why, as Laura said, we need a team. And today, with the support of my mentors, I'll be presenting my research, evaluating and re-evaluating surrogate subtype classifications of breast cancer. So as we just heard from Teddy, breast cancer is not one disease. And we've been making steady advancements in subtyping to better reflect tumor heterogeneity and to personalize treatments. So to briefly go over the history here, we went from examining cancer cell morphology under the microscope, identifying the ER receptor and developing endocrine therapies, to identifying IHC markers with HR and HER2 and developing targeted HER2 therapies. And now we have gene expression-based molecular subtype assays, as you've heard, like Blueprint and MammaPrint, which together classify tumors into basal type, HER2 type, luminal A, and luminal B. So the way this works is Blueprint first interrogates the mRNA expression levels of 80 select genes to classify tumors into basal, HER2, and luminal type. And the luminals are further stratified into luminal A, and B by the 70 gene risk of recurrence signature mammoprint. And as you can see here, these molecular subtypes predict response to different systemic therapies to inform treatment decision-making. However, such expression-based molecular subtyping assays are not routinely accessible due to financial and insurance barriers at present. And so in the absence of molecular profiles, IHC markers like HR and HER2 have been traditionally used as a surrogate to approximate them. In fact, the National SEER Registry uses these IHC-defined subtype surrogates. And when our team went in to examine the distribution of luminal B cancers, the subtype that Teddy showed has a poor response to their standard of care, we found that SEER defines luminal B simply as HR positive and HER2 positive, as listed here. However, we hypothesize that such IHC-defined labels probably don't reflect molecular subtyping that are done by gene expression profiling. And so we asked, can IHC-defined subtypes be used as surrogates for gene expression-based molecular subtypes? To answer the question, we compared IHC subtypes to molecular subtypes by a combination of the mammoprint and blueprint in 2 breast cancer cohorts. The I-SPY 2 trial, which you've heard about, is for patients with mammoprint, high risk, early stage breast cancer with subtypes defined by HR/HER2 and mammoprint and blueprint. And the FLEX registry, it collects HR and HER2 and mammoprint and blueprint in addition to a variety of tumor characteristics that you'll see later. And so when we did this, you're seeing 2 safety plots here, one for I-SPY and one for FLEX, that show IHC subtype surrogates on the left and the way they map to molecular subtypes by mammoprint and blueprint on the right. And we found that the mammoprint and blueprint reclassified IHC-defined subtypes nearly half of the time in all cases, at 52% in I-SPY and 43% in FLEX. And this rate of reclassification did differ by IHC subtype. So for HR negative, HER2 negative tumors, they actually did largely correspond to molecularly basal type with 99% concordance in I-SPY and 88% in FLEX. However, concordance was low for HR positive tumors. So for HR positive, HER2 negative, none of them were molecularly luminal A in I-SPY 2, which does reflect the I-SPY study eligibility criterion requiring them for high risk. But concordance was still low in the more population-based FLEX registry at only 55%. These HR positive, HER2 negative tumors were instead reclassified as molecularly luminal B in 71% of I-SPY and 40% of FLEX registry cases. For HR positive, HER2 positive tumors, which SEER defines as luminal B, only 28% in I-SPY and 47% in FLEX were actually molecularly luminal B. And these cases were reclassified as molecularly HER2 type in 71% of, in 60% of I-SPY and 36% in the FLEX registry. And perhaps most strikingly, of the molecularly luminal B cases, only 14% in I-SPY and 7% in FLEX were actually HR positive, HER2 positive. So to answer our question, we find that IHC-defined subtypes in SEER are not accurate surrogates for molecular subtypes, especially for HR positive tumors and luminal B tumors. And we proposed that SEER start reporting IHC labels by HR and HER2 only, instead of using their IHC-derived surrogate subtype nomenclature. And we're happy to share that they have actually fixed this as of April. And that, when molecular profiling information is available, to begin incorporating it. But while we hope for and expect increased molecular subtyping, we also recognize that such assays are not routinely available at present, which led to our next question. So we asked, can we devise a better surrogate? Can routinely collected variables be combined to accurately reflect molecular subtypes, especially for these luminal B tumors? To explore this, we examined patients in the FLEX registry who had complete information across 11 variables listed here, which contain routinely collected variables in breast cancer diagnoses. These include but extend beyond the ER, PR, and HER2 status. To devise our own surrogate algorithm using these 11 variables, we performed recursive partitioning, which is a statistical method to determine which factors and in what order are most important for predicting a particular outcome, which in this case is molecular subtyping by mammoprint and blueprint. So our surrogate algorithm from recursive partitioning is displayed here. So of the 11 variables, only 3 were selected: ER%, HER2 status, and Ki67, which is a proliferation marker. The first branching point, as you see, is ER%. On the left branch, tumors with low ER% were classified as non-luminals. Those that were HER2 negatives were then defined as basal type, while HER2 positive as HER2 type. On the right, tumors with high ER positivity were called luminals. Those with Ki67 greater than or equal to 19% sorted into luminal B, and less than sorted into luminal A. And the number of cases labeled and the accuracy of this recursive partitioning surrogates are at the bottom of each of these buckets here. Okay. So using our recursive partitioning surrogate definitions at the top, we assess the performance by subtype as listed here at the bottom. And the validity measures of interest were the overall concordance between our surrogate and the molecular subtype, the sensitivity for luminal B, which is the proportion of true luminal Bs that our surrogate calls luminal Bs, and then the positive predictive value, which is the proportion of our surrogate luminal Bs that are indeed truly molecularly luminal B. And then we placed our surrogate in the context of other existing surrogate classifications to compare their performance. So the rows here represent 6 different surrogate algorithms. The first one is IHC, so that was what Sia was doing. Second is clinical practice, which incorporates tumor grade to differentiate luminal A and luminal B. And 3 iterations of St. Gallen, which is an international consensus conference of breast cancer researchers and clinicians. And then our algorithm here. So in looking at our validity measures, we see that our recursive partitioning isn't bad, but not great. It has the highest concordance overall at 70.9%, but it's not sufficient still for molecular subtyping. And it has only a 2/3 about sensitivity for identifying the luminal B cases. So then returning to our question of, can we devise a better surrogate using routinely collected variables? Not particularly well. So the best our algorithm could do was to identify about 2/3 of the molecularly luminal B cases. And furthermore, our algorithm classified using ER%, HER2 status, and Ki67, but Ki67 is not always available or routinely standardized. So maybe to make molecular subtyping the standard of care to guide personalized treatments, the way to go is to move forward and prioritize the molecular subtyping rather than backwards and just sticking with the IHC subtype. And maybe a world in which the pathologists have the kits for molecular assays like mammoprint and blueprint may get us there. To conclude, clinical pathological features cannot sufficiently substitute for expression-based molecular subtyping. This is clearly important at the individual patient level, as the subtypes are predictive of response to systemic therapies and thus can and should guide our treatment decisions, as Teddy also showed us before. And next, you will hear from Paige as to why having these accurate subtypes is so important at the population scale too. I want to thank everyone that I've had the incredible opportunity to learn from. It was an amazing experience to be here. Thank you.
I just thought of another really important conclusion for you.
Great.
For your paper.
Yes.
Even more than seer, what's in practice? What are people doing?
They're using Ki67.
They're using St. Gallen.
Right.
The 2015 compared to that, how does that perform?
Actually, the 2011 and 2013 cutoffs are more widely used.
But they're more widely used in practice?
In papers that I've read.
Yeah, but
Yeah,
so but they've so we probably should tell them, like,
Right.
your update's terrible.
I know, and there was actually the inspiration for doing St. Gallen's 2015 is there was a paper that was like St. Gallen's 2015 is great. So we can respond to that.
Okay, fantastic. Okay. Not so
Yes.
great. In a nice
Right.
way, in the nicest
Right.
possible way.
Right.
And you can write, and by the way, invite us to your next conference.
Oh,
We'll be
in
happy
St.
to-
Gallen.
Tell me you'll be
In
be
Switzerland?
happy.
Yeah.
to send. Questions from the audience? Anybody else? How are we doing? Okay, anyway, this is fantastic, and I think it is actually really interesting, but I think that point you made about, adoption practice, and this is another thing that I try and teach all of you to look at. There are many things that influence whether people adopt new strategies, right? So why is it that you think that the pathologists aren't so excited about doing molecular subtyping?
About money. It's about money.
Or
And
about
so-
and their business, what they
and
do.
business. And so IHC is expensive, as you explained to me. And if we are
But who does it?
the pathologists themselves do it, the institutions get it. And so the institutions would be doing the business. Right now, the molecular subtyping like mammogram and blueprints are not done at the local level, but they're done by a company called Agendia. So if we can find a way to get those kits to the local pathologist,
Yeah.
then maybe we would have more uptake.
I think smartly Agenda is thinking is working on that strategy, which is, but it's just not something you would all think about, right? But who does what and who wins doing what is all that dictates 80% of what happens. Great job.
Thank you.
Fantastic. Okay. And as promised, Paige is now going to tell us why we care, why we should continue to care. Why we should care, like how we should extend this even further and think about this and help ourselves figure out what to do next about the problem of the luminal.
You can do it. Yeah, actually, you can do it after I go through what I learned. So I'll go to. Okay, we're gonna pause. There we go. Okay, so as we get a good look at M&M, I'll say what I learned most about this internship, which is you should go outside of your comfort zone a little bit in terms of your research interest, because I came in thinking I wanted to do one thing and came out doing some epidemiological research, which I learned many different perspectives about, and may continue as I enter school and find new research projects there. So what I would say I learned. And then you can start playing it. Yeah. We had to go, Nikki Schindler told me to go big or go home. So we went pretty big. So now that I have your attention, for at least the people who were born prior to 2000, my name is Paige Warner, as Laura mentioned, and I'm posing the ever important question, will the real luminal bees please stand up? However, before we dive into identifying these luminal bee breast cancers, we need to soak in what Teddy said about response predicted subtypes. And more importantly, we need to recognize the overarching point that not all breast cancer is the same and tumors don't grow at the same rate. So in order to cure all breast cancer, we need to look at it as more of a mosaic of individual subtypes that behave differently and are not found in equal proportions among different populations. So therefore, it's crucial that we create different treatment and prevention strategies. As of now, response predicted subtypes are not widely used in clinical practice. So, and they're pretty novel, as Teddy was going over. So intrinsic molecular subtypes are more commonly used. And these 4 groups below are based on gene expression patterns that mimic looking under the hood at a cell's DNA. Within this classification, we find the luminal bees. But why do we care about them? Well, they're distinct because they are deceivingly aggressive. Even though they have positive expression of hormone receptors, like the generally less aggressive luminal A's, luminal bee patients generally have poor prognosis and a higher proportion of recurrence and metastasis. And that's why we care so much about these luminal bee breast cancers, because we assume that they'll be easy to treat like the luminal A's, when in fact they're largely resistant to endocrine therapy and chemotherapy. And in addition to being hormone receptor positive, they also tend to be higher grade, like these grades 2 and 3. Luminal beads are also essential to identify because they're not an outlier among breast cancer patients. In fact, within the hormone receptor positive or HR positive group, which make up around 80% of all breast cancers in patients stages 1 through 3, we estimate that around 28% of the cases are made up of luminal bead breast cancer. So this is not a subtype that we can ignore. However, before intrinsic molecular subtyping came immunohistochemistry or IHC subtyping. And while molecular subtyping looks under the hood at the cell's behavior, IHC subtyping gets a little less comprehensive yet still valuable picture by looking over the hood at a cell's physical features, like the receptors that it expresses. And there are 4 receptor subtypes which roughly map to the 4 molecular subtypes, but as Jane just confirmed, that we don't have an optimal receptor surrogate for each. We do know that luminal beads are distributed across 2 IHC subtypes, which are the HR positive, HER2 negative, and HR positive, HER2 positive groups. So we can at least narrow down luminal beads to having hormone receptor positivity. And while no optimal receptor surrogate exists, the purpose of my study is more epidemiological in nature than clinical. That is that I'm looking as close as possible or as close as we can get to the broad patterns in subtypes that best approximate our most susceptible populations. And as close as we can get can be found in the gold standard of cancer registries, as Jane mentioned, SEER, in which you learned that it does not include intrinsic molecular subtyping. Therefore, with the goal of determining the distribution of luminal A and luminal B breast cancers by race ethnicity, I ask what combination of data elements in SEER will approximate luminal A and luminal B breast cancers. I said when explaining the IHC receptor subtypes that luminal Bs are restricted to being HR positive, and we can also use grade and mortality to represent the aggressiveness of the cancer. So my method is to measure incidence and mortality among HR positive cancers, which are stratified. I'm going to stratify by grade. And this is what we find. So at the bottom of the slide, the arrow shows that I'm putting HR positive grade 1 cancers into the luminal A bucket and HR positive grade 2 and 3 cancers into the more aggressive luminal B bucket. And looking at incidence in our navy boxes, we see that while for lower grade HR positive cancers, non-Hispanic whites show higher incidence rates, they actually show a lower incidence rate than our non-Hispanic Blacks in the HR positive grade 3 group. Now, if we switch to mortality rates, the risk of dying is similar between HR positive grade 2 and 3 cancers, but the numbers are more difficult to analyze because less women are dying of breast cancer than are being diagnosed with breast cancer. So to account for this, we calculate the mortality incidence ratio, or MIR, that if you pay attention to the graphic at the bottom is just mortality divided by incidence. And what this metric shows us is it represents the severity of the type of breast cancer. And this figure also shows that across the board for all races and ethnicities, the mortality incidence ratio increases with grade. So as we would expect, the higher the grade, the more severe the breast cancer, because it's causing a higher proportion of women to die of it. Additionally, for all HR positive cases, non-Hispanic Blacks exhibit the highest MIR compared to other racial and ethnic groups, while non-Hispanic Asian Pacific Islanders consistently have the lowest mortality index proportion. Now, if we combine these results with the original question I posed, will the real luminal Bs please stand up? We can summarize that we're going to have a problem here. We did get around this problem by using high-grade HR positive cancer as a rough surrogate for luminal B breast cancer. I found that higher grades have a higher mortality incidence ratio. And we added another layer of race and ethnicity to this mortality grade correlation to find that non-Hispanic Blacks have the highest mortality among all HR positive breast cancers, while non-Hispanic Asian Pacific Islanders have the lowest proportionality. But in the end, why should we care about these findings? Well, even with these results, we still need to remember that national and local registries are not keeping current with the diagnostic and treatment advances, and we can do better. There needs to be a push for improved and standardized data collection in SEER and other local registries for as many data elements as possible, such as Ki67, oncotype, and molecular subtyping. Also, molecular subtype matters not only for treatment, but also for screening and prevention. So clinics nationwide need to modernize the way they characterize tumors in the first place. We should also care about our catchment area, where the majority of UCSF cancer patients live. Here we want to see who is at risk for what type of breast cancer and where, specifically among our luminal B patients and cases, so that UCSF can implement policy and direct patients to the most relevant clinical trials for them. In fact, I have these mortality graphs that are hot off the presses as of 2 days ago that confirm the suspicions that we saw in our MIR bar graph that I just showed. That even though the data within our catchment area is limited, non-Hispanic Black women are dying disproportionately more than the non-Hispanic, Asian Pacific Islander, and Hispanic women of these HR positive, HER2 negative breast cancers. And this group of non-Hispanic Black women that I boxed in navy may be a major group that falls into the luminal B group. So now to conclude, it is this funnel that drives the impetus for our search for luminal Bs in the end. You've already heard from Teddy how breast cancer subtypes impact treatment options and outcomes, and how luminal Bs may not respond to treatment as well. But we want to identify where these tumors occur and who is at risk for them so we can more accurately target prevention strategies. And we'll likely see different approaches to that in luminal As versus luminal Bs. So if we make widespread molecular subtyping and point of care data collection one source, perhaps we can we can finally improve treatment, screening, and prevention for breast cancer subtype that will finally be able to stand up. And I'd like to thank mentors, collaborators, all support and creative design elements to this, and all of you, of course. So thank you. This was actually from last year, like at your house. Yeah, he was on the ladder. Yeah.
All right, awesome. With the paper plate awards. Okay, so great job. You preempted my question about one source, so I'm like, kudos to you. Yes, but we're going to hear more about, I think, one source. All right, so my question to you is, in your grade, are you catching only luminal Bs, you think?
No, we're actually catching in our more high grade cancers, we're actually catching some basals as well, which I can go back to this pie graph right back here, where about 12% of our HR positive cases are basals, and way back here. Sorry about that. I'll get to it, I promise. Okay,
Yeah.
yes, there we go. So these 12% that you see here.
Yeah, so as a total, though, it's still about a third or a quarter, right, of these, of what those of the three. So I would just add that.
Yeah.
For the figure in your paper. Okay, questions from the audience? Is there anything on the chat? Yes.
The collection.
Yeah, so why aren't they collected? So the first barrier is,
Yeah, so the first barrier is insurance and cost to these molecular subtyping. But as we've seen, and as Jayun has touched on as well, that after you do some of these IC testing like KS67, the cost actually is going to outweigh the molecular subtyping tests in some ways.
the first barrier is that people aren't ordering. It's not routine.
Yeah.
Actually, and it's interesting. There's more than one way of ordering. Yes, there's different molecular tools, and so the penetrance in the market of Oncotype is much higher than the penetrance of, say, the not signature on the PAM50 test or Agendia. And I will tell you what the reason for that is, because when genomic health was invested upon by of the venture capital money that went into it, 85% went to marketing. So, which was a very good strategy because it made it very successful. But it did lay the groundwork for the adoption of something more than molecular tests. But it is actually also people getting set on one test versus another has also limited our ability to get additional information. And I think that's one of the reasons why I think the response predictive subtypes of the idea that you can get much more from a test that has 40,000 genes compared to something that has 21 It gives you a lot more degrees of freedom. It will take time. So what is adoption? And then the second thing is the registries themselves.
Yeah, the registry. So there has to be a reason for the registries to collect it in the first place. So clinics need to first collect it and then report it to SEER, which does take time. So there's always a delay with these kinds of things.
And as you said earlier, the best way to do this, however,
is point of care data
and then
collection.
with everything and then sending it to the
And
registries.
then,
And we're going to be piloting that. Those of you who are on the One Source project next year, raise your hand. And where is, let's see, where is engineering? So there should be 3 of you. 1, 2, 3, right? One Source, right? One Source, hands up. Everybody needs the One Source. Why everybody needs the One Source people. So fantastic job. There's a method to my madness, right? All of these things are actually really connected. But one of the things that I'm so excited as I'm seeing all of these presentations is that, I think it's really great to see how everyone is relating what they're doing to everyone else. And that's, as I said to you yesterday, or whenever, Wednesday, whatever, all a blur, that it is really important for you to understand how you fit in the context of everything else that's going on, and your ability to make progress really depends on all the work that everybody else is doing. All right, so now we're going to turn to another type of tumor, which, by the way, there's probably half of lobular cancers are actually also luminal B. So that's another very interesting aspect. So we're sticking in with our conundrum of hormone positive breast cancers and what they may mean. And so our next up is Annie about lactobacillus blast.
Great, thank you. While I'm clicking through, I will start with the thing that I learned this year, and I would say, here we go. Okay. So I would say I learned to say yes and seek out opportunities that are interested to me. I've learned from providers that I've worked with here, Dr. Astaman, and all the other interns, that there's always time to make time for a project that's important and exciting to you. And I hope to bring that work ethic and passion into my future career. So starting off today, my title is about Target US to establish intraoperative radiation therapy efficacy for invasive lobular carcinoma. So to start off, over the past 40 years, there's been a dramatic change in the local management of breast cancer, with radical mastectomy being replaced by breast-conserving surgery and radiotherapy. And in terms of radiation therapy, there was also a paradigm shift to argue for avoiding unnecessary treatment to the whole breast and limiting radiotherapy to only a portion of the breast. A randomized trial titled Target A showed that intraoperative radiation therapy was non-inferior to traditional external beam whole breast radiation therapy for select patients. Intraoperative radiation therapy allows for delivery of a single fraction of radiation to the lumpectomy site while in the operating room. This device is inserted after excision of the tumor and is switched on for somewhere between about 15 to 40 minutes to provide radiation accurately targeted to the tissues that are at the highest risk of local recurrence. So you can see that with targeting, they've finagled the acronym to spell out the target trials. So that's a little bit of background that people do ask. There are many benefits to intraoperative radiation therapy. One benefit simply is time. This treatment takes less time for a patient and providers because radiation therapy is delivered during surgery, and there's also no gap and therefore no delays between surgery and radiation. A second benefit is ease for patients compared to conventional radiation therapy, where they typically would be coming in for treatment 5 days a week for about 5 to 7 weeks, which is obviously a huge burden. Additionally, there are fewer side effects with radiation precisely targeted to the tumor bed. Radiation exposure is limited to other areas of the body, and this also results in less fatigue, better cosmetic results, and faster recovery times. The Target US study is a registry for women with the listed eligibility criteria. This registry will increase the general knowledge regarding this form of radiation and allows for further assessment of risk groups. Postoperatively, some pathologic characteristics may be found that render a subject at higher risk for local recurrence, like extensive intraductal component, positive nodes, positive margins, and invasive lobular carcinoma. If that is the case, according to the center's treatment policy on Target US, the patient will be recommended to have a full course of full breast external beam radiotherapy. And so for this research, we are focusing in on the high risk feature of invasive lobular carcinoma. Invasive lobular carcinoma is a type of breast cancer that begins in the milk producing glands of the breast, which you can see visualized here. Invasive lobular carcinoma accounts for 10 to 15% of breast cancers and is the second most common following invasive ductal carcinoma. Invasive lobular carcinoma has been considered a contraindication for intraoperative radiation therapy because of its diffuse growth and multifocality, making it more difficult to get clear margins, which, as you may remember from the previous slide, is also an indicator for external beam radiation therapy following intraoperative radiation. For the target studies, both the randomized trial Target A and the registry study Target US, if ILC is identified on the patient's initial biopsy, the patient would have been excluded. Separately, if the tumor histology is identified as ILC on the final surgical pathology, this is considered a high-risk feature and external beam radiation therapy is advised. From this, we have a cohort of patients with invasive lobular carcinoma that received IORT on both the Target A randomized trial as well as the Target US registry study. There's been small series published allowing ILC, invasive lobular carcinoma, to be considered for intraoperative radiation therapy treatment, but it's known that further data from phase 3 and 4 trials is necessary to conclusively establish the efficacy for patients with invasive lobular carcinoma. So knowing this, we ask the question, in the Target US study, are there significant differences in the patient and tumor characteristics or 5-year disease-free survival between invasive ductal carcinoma histology and invasive lobular carcinoma histology? So moving on, we have a table here with some patient, tumor, and treatment characteristics, which we have broken down by histology. First, I'd like to clarify that our ILC cohort does include ILC and mixed IDC ILC. Additionally, I'd like to explain some of the numbers for the cumulative N values and their variations. There's still a lot of work to be done with the Target US data management with our affiliate sites. So unfortunately, not every field is available for every patient. We are hoping to improve this, and Kat will be setting up for this for next year. Kat's my trainee. Our cohort is made up of 1,157 participants that completed intraoperative radiation therapy. 1,081 of these had IDC, and our cohort of ILC is 76 patients. Just to go over some things that we learned from this data, for the hormone replacement therapy use field, which is captured as the use of hormone replacement therapy at any time point prior to diagnosis, we found that it was used in 31% of the invasive ductal carcinoma cases and 41% of the invasive lobular carcinoma cases. This is not quite statistically significant, but it's interesting. For the receptor subtypes, we found no statistical significance. When looking at these, it's important to remember the eligibility criteria shown on prior slides. And so in some of these cases for receptor subtype, they wouldn't have qualified on initial eligibility, so it changed before their final surgical pathology. We do not see a significant difference in tumor size, but the average size for invasive ductal carcinoma was almost 12 millimeters, and the size for invasive lobular carcinoma was 9.6 millimeters. There wasn't a significant difference in node positivity. Grade is significantly different as expected with invasive lobular carcinoma, more at grade 2. There's no statistical difference in clear margins or additional surgeries. Finally, with external beam radiation therapy received after intraoperative radiation therapy, This is significantly different as expected. However, we find this surprising because we would have thought that a higher percentage of the invasive lobular carcinoma cases would have external beam radiation therapy. So I'd be interested in reviewing this further to learn at which sites this was not offered and to learn if at particular points patients declined. Key takeaways from this, looking at the data, we see that there were not significant differences in node positivity, clear margins, and additional surgery required, which could be similar to high-risk feature indicators for additional radiation therapy treatment if they had ILC. Moving along. For disease-free survival, we looked at the question, is there a difference in disease-free survival of people with invasive lobular carcinoma versus those without ILC? The estimated cumulative 5-year disease-free survival for IDC was 96.95%, ILC was 96.54%. These are both very high, and we did not see a significant difference in 5-year disease-free survival for the target US patients with IDC and ILC. Moving right along, we also, when looking at the covariates listed here, we found that the only significant value was that the size of tumor on final pathology showed that for every 1 centimeter increase in size, there was a 16% increased risk for local or distant recurrence. Our final findings were that the cohort characteristics were comparable for the IDC and ILC groups, and the 5-year disease-free survival was not significantly different. In terms of next step, we hope to continue follow-up for patients on Target US to extend our follow-up time and completeness of our report forms. Additionally, we hope to target the consolidation of the Target A and Target US trials to improve patient cohort and follow-up. Thank you. Thank you to Dr. Mokhtar and Dr. Alvarado for their help with this project and all of my other mentors and interns this year. Thank you.
Yeah, great job. So, you know, it's interesting that, so at the beginning, what do you think though, why do you think that the lobular cancers were excluded from the beginning?
So because, thank you for that question. We were, we have met with Dr. Veda, who worked on the Target A trial. And basically in his explanations, there's the initial basis that lobular cancer is more difficult to achieve clear margins because it's diffuse growth and multifocality. So that was something that they considered when they were excluding them, because it would be more difficult to not require external beam radiation therapy after intraoperative radiation therapy. And yeah, I guess that's my answer.
Yeah, and so, so that probably, so who, you know, when you're trying to do something new, when you're trying to do a trial, what is probably the most important thing that you have to do when you put out a new idea?
To make it work for something that you think it should work for, right?
Yeah, but so when you do something, is everyone excited about doing something new? Is everyone a champion of change?
No.
No. So one of the most important things you have to realize is you have to start thinking about who is in my way, or perhaps nicely, who might not like this, and who might block the adoption of this. So who, when this came in, who do you think might have blocked the whole idea? So this is going from, right, so we went from radical modified mastectomy to modified mastectomy to mastectomy plus radiation to then maybe just lumpectomy. And like we've shown actually since 2005, and now just at ASCO, they showed even women 55 and up, there's not really much benefit to doing radiation. Has that been widely adopted?
No.
And why not?
Because people are resistant of change.
Yeah, people are resistant to change, especially when it's your livelihood and you like believe that it works. And it's not a bad, you know, it's just, that's just the way it is. It's not about good or bad. It's about, that's how people behave. So you have to know that when you're trying to make change, you have to think about where the opposition is going to come from. Right. And so this might have been one of the arguments, right? And originally, the original trial of radiation versus no radiation was in women over the age of 70, and it was up tumors up to like 5 centimeters, and they had to move it down to 3 centimeters because the radiation therapy completely blocked the trial. So why do you think, I'm going to ask you again, why do you think that lobular was excluded from and required EOR, external beam radiation? Who was going to block the trial otherwise?
Radiation oncology.
That's right.
I also think when we were having conversations with the original Target A trial team, I also think the device in the company that sponsors the device was involved with some of those conversations.
Oh, for sure.
And so I think that was one thing that we discussed when talking about all the data.
Another thing is, so lobular is about 20%, 15 to 20% of all patients, right?
From my citation in this presentation, it was 10 to 15%.
Okay, so it's a small subset. And what happens to small subsets?
They get excluded.
Correct. And that's actually not fair. And they actually get, even though they weren't excluded from the trials that say no radiation is necessary, the assumption is that they were excluded. And so people don't do it, and they aren't a big component of it. They're underrepresented. So people say, oh, well, aha, you haven't shown it, so we're not going to do it. So your data shows perhaps even more important, if the IORT is not adding much, what are all these patients also taking to reduce their risk? All these patients on Target are
Endocrine therapy.
on endocrine therapy.
And we do collect that data for.
Correct. And so this also shows that endocrine therapy, which might be what's really working, is also successful in lobular patients, which a lot of people say they're not, right? But one way to figure out where your treatment is good enough, whose presentation today would help us tell, before you give any of these therapies, which therapy is good enough? Yours, and who else's? Oh, she's
She's
lunch.
lunch.
Okay, and Ulysses, right? So this is why you ask, so this is a really important question. The way to figure out whether, could a lobular, just because you're lobular, does it mean you're not going to respond to hormone therapy? Do we really understand that very well?
We need to study it more
And how are we going to do that?
by recruiting more lobular patients to these studies.
To be in the trials and not exclude them from the trials. Because if you are a good responder on that bottom curve, those great responders, what if you're one of those curves? You're going to need radiation? Why not? So I think this is again, how important these trials are. And it's so important that you guys did this. So even though it's a small subset, it's absolutely essential that this get published. I'm sure Rita's going to push you to publish it anyway, but sure. That's the question.
The question is if we're collecting patient-reported outcomes and long-term. So for the Target US registry trial, our follow-up is 5 years, and we're specifically following up through patient records. So there's no patient-reported outcomes.
No, it was a low-budget trial, so. And besides, they didn't have, who's speaking of that? Emma. We're going to learn how to do patient-reported outcomes in an affordable way. But it's taken us a long time to figure that out. So we're there. All right. We're going to give everybody, thank you so much, Annie. Fantastic job. All right. And we are, we're going to pause for our recording, and we're going to resume at 1:15, and we'll be back on track. Okay. Okay, excellent. We're resuming our talks. Fantastic morning so far. We're going to resume with Eliza Hurst, a topic near and dear to my heart. Of course, every topic is near and dear to my heart. And of course, don't forget everybody, this afternoon the same as this morning. Most important thing you learned is what you start with. Okay, this year and forever. Okay, Eliza.
Okay. hold on.
Just click into the icon.
Yes, ma'am. Okay.
What
Is
you
there a
want.
way to move this
Yeah,
little?
just minimize it if you see it on your screen.
I don't. Help.
No, hold on.
Rashna knows all. Okay, while Rashna is doing that, the thing that I learned while I've been here is that you really can't do anything by yourself, and everything can be done with a team, especially using scribes. But yeah, that really teamwork is what makes all of this possible. Okay. Oh no, oh no. How do I move the Zoom thing? Okay, great. Okay. So everybody, hi, my name is Eliza, and I'm going to talk to you about the role and the value of medical scribes. So there are really two kinds of scribes that exist. And interestingly, they both came onto the scene around the same time in the early 2000s. And as their names suggest, these two different kinds of scribes actually work to support different parties. And what's really interesting is that in this 8-year time span, we see a really big growth in the use of one kind of scribe over the other. So patient scribes are available in 2 hospital systems as of last year, but physician scribes are available in 3,500 partners worldwide. And this kind of begs the question, why are we using one type of scribe so much more than the other? And to answer that, we need to be thinking about what role physician scribes are playing and what niche they're filling. And these are typically pre-med undergraduate students or post-bac students who are trained to work specifically with medical providers, and their job is to document in real time what's going on in the encounter. And so the goal of their work is really to save physicians time so that they don't need to do huge amounts of documentation after each appointment. And in order to really evaluate the function and the utility of these scribes, we identified 3 key stakeholders. So physicians, patients, and then the scribes themselves. And what the question we were trying to answer is really, what benefit are these 3 stakeholders deriving from these scribes? So for physicians, physicians are really finding that scribes are helpful with efficiency. It's streamlining their workflow and enabling them to be more present in appointments. And then patients are finding that because their doctors, like this quote is saying, actually, my doctor had the support that she needed to give me her undivided attention, patients get this really indirect benefit that because their physician is supported, the patient is supported. And so looking at these quotes, we see that the niche that these physician scribes are filling is really administrative. And the benefit to the patient is very indirect. But we do want to evaluate what benefit are the scribes themselves getting from this experience. And through looking at what they do, we really identified these 3 areas that physician scribes build skills in. It's medical knowledge, professionalism, and patient care. So it is kind of a small area of growth because the role of a scribe is pretty limited. They're not allowed to talk to patients. Their job is specifically to help physicians, but you really can learn quite a bit. I actually used to be an emergency department scribe, and I learned a lot, but not quite as much as this other option that I'll get to. So to summarize, really for physicians, these scribes are about efficiency. They're very helpful, and they really do serve an important purpose because documentation takes a lot of time, as I'm sure people on Zoom can attest to. For patients, very indirect benefit. And for the scribes, it's a great opportunity to be a part of the healthcare field and really see what it looks like and build some of these skills. But what if there was another option that could do these same 3 things, but take it all one step further? They could do quite a bit more. And that's where we get to patient scribes. So hopefully everyone in this room knows about the PSE. So if you don't, just to quickly summarize, the patient support corps interns are patient scribes. They work to help patients, and really in these 3 different time points. So before the visit, meeting with the patient, building a question list, understanding and organizing the patient's thoughts before they meet with their oncologist. During the appointment, recording and documenting and writing it, the transcript of the visit in a way that's really patient-centered and that patients can understand. And then finally sending those notes to the patient as well as the recording, giving them an unbiased record of what was discussed in the appointment. So in order to evaluate the benefit of these scribes, for those same 3 stakeholders, we use the PSC exit survey. This is a survey that we send out to all BCC interns at the end of their tenure, asking them to reflect on their time in the PSC. And through that, we have a lot of really wonderful anecdotal data about what PSC can do for these 3 stakeholders. So we'll start with physicians, just as before. In reading through survey results, we found this theme emerge, that QLs are revealing critical gaps in patient knowledge and provide opportunities for physicians to educate and support their patients. This is best demonstrated with this anecdote here. So this PSC intern was working with a metastatic patient, building a question list, and it was revealed that the patient didn't entirely understand what the implication of stage 4 cancer was. Because the oncologist and the patient were going through the QL during the appointment, the oncologist was able to dedicate extra time to explaining to this patient what that meant. And although this was really emotional and shocking to the patient and her family, because it was delivered in a compassionate and skillful way, it actually brought the physician and the patient closer together. So because this was written out and was something they could go through together, it gave both the patient and the physician the opportunity to discuss, what does it mean to have stage 4 cancer? What is metastatic cancer? Okay, so then thinking about patients, what benefit do patients get from this experience? Came to 2 different things. We'll start with the first one. So the CRS, which is the reporting and the consultation summary. This is an unbiased record of what happened in the appointment. And this gives patients a way to refer back to something as many times as they need in order to make treatment decisions. Just like a physician scribe is helping physicians be present in the appointment, patient scribes mean that patients don't need to be taking rapid notes, trying to understand all the terminology. It's written down for them. And their QLs stimulate conversations about the patient's goals and values. And that is shown in this anecdote. So this was another metastatic patient. And in building the question list, it was revealed this patient really wanted to avoid chemotherapy. And it was when they discussed it further, she revealed her mom was actually about to die. And the patient did not want to tell her mom, I'm going to die soon too. And so because they had this conversation and the intern put this into the question list, the oncologist and the patient then could have a discussion about, let's talk about why you don't want to go through chemotherapy, help the patient understand why chemotherapy could be useful, and then actually built her chemo schedule around her visits with her mom. So this patient then became someone who could treat metastatic cancer to the extent that we can, and was able to maintain a healthy appearance when she did spend time with her mom. So really valuable experience for the patient. Haley's going to get into this a little bit later, but these conversations can be different between patient to patient. It's really important to identify these things ahead of time. Okay, so then in order to understand how this is valuable for the scribes themselves, we used the ACGME competencies, and this is the Accreditation Council for Graduate Medical Education. This is like the competencies we use to evaluate residents. So we ask PSC interns to rate themselves in these 6 core competencies before and after their participation in PSC. And what we see is in every single one of these, in all 6, interns rate themselves as having improved by upwards of 20 points. They're rating on a scale of 0 to 100 with an average of 24 point increase. So we're really seeing a huge increase in these skills that most people are developing through their medical education, but it's actually before they even start. So it's really exciting to see that we can be working on all of these different things that are very important to being a physician before you even start on your medical career. And of course, that it's attributed to being a part of PSC, not just everything else you do at the BCC, specifically PSC. Okay. So then what can we take away from this? maybe there's a future where we can use patient scribes as often as we use physician scribes. And in this ideal world, patients are constantly feeling supported. Physicians can have these valuable conversations easily with these written records, and scribes can learn all these valuable skills and really be a part of the care team much more than they can strictly as physician scribes. I just want to quickly say thank you to Jeff and Dr. Esterman, and then of course, all of my fellow BCC interns. I could not have done any of this without you guys and everything you've done for PSC. So thank you.
Thank you, Eliza. And as you know, I specifically hired you because of your scribe experience, because at our first Sparking Innovation and Healthcare Value, we will be resuming this coming spring, next year, June, Jeff had made this comment about how patient scribes were not being used and physician scribes had taken up. Now, of course, that's because all the physicians were going to resign en masse, and so this is what in order to force people to keep using the current electronic medical record, that's what the response from the hospitals are. Eliza, do you think it's likely that we'll be able to replace physician scribes?
I don't think that, sorry, the question was, can we replace physician scribes? And no, I really don't think that's a super likely option. I think probably we'll be able to combine the work that both of those scribes do.
Exactly. And so what is a lot of what the scribe is writing down?
Like all the things that appear in
Pertinent
the chart.
facts, right?
Yeah.
Okay, who wants to volunteer to say what could replace a lot of that?
One source.
One source. 2028. Inside joke. Newskit people will understand that. All right. So, but I mean, again, if it's the point is to be more, have a little bit more discipline about what we collect. Because if our job is to improve what we do, what's the most important thing? The most important thing to improve something is to do what?
To help the patient. It's all about the patient.
Right. But how do you improve something if you don't know what you're doing? You have to. The first step is to
know what you're doing.
Collect. Yes, have some structured collection. Right. So, is it some mystery? Is it for all of you who do patient scribing? Is there a mystery to the data we collect? Is it the same? I mean, there's a bunch of basic information that everybody has to have, right?
Yeah.
Mystery? No. And do we have to collect it every time? No. So if you have that is already done,
then we could just have patient scribes.
Exactly. I think it's time to start a whole new health plan. All of the former interns, and then we just think we'll have like a cast of 400 to go. All right, questions are there? Who's monitoring the chat?
Yeah.
So my question is,
They're only here, so this is a little thing on one.
Mhm. I have to admit, I'm not very familiar with what patient navigators do, but I think anyone who works at UCSF who's interested could be trained in being a patient scribe. I don't think we need to limit it to a certain student intern group.
No.
It really could be, even physician scribes could be trained to be patient scribes.
Of course, anybody can do it. And in fact, we did in Ukiah, we actually had a program where all the navigators learned how to do patient question listing. It's just a more formalized way to do it. So it's just a technique.
Yeah.
For making sure that you understand things. And actually we sort of developed this. This was Jeff's thesis project back in 1990. 1993 or 1994. And guess who was his thesis advisor? Anyway, but it came because Jeff was, I had a patient who, again, as a physician, I thought that what mattered most to this patient was having a reconstruction. But what mattered most to her was going on this trip, this cruise with her mother, which she missed because she had a complication of her reconstruction, could not go. And when I went back and read Jeff's notes, because he was the original patient thread, I was like, okay, I thought I was listening, but I was mostly listening to what my values were, not what her values were. And so this is, again, this is why in your training, for all of you, just let me make this really clear. PSC is not optional. There are a couple of jobs where people have more limited ability to do it just because their schedules are a little higher, but it is not optional, not optional. This is a core part of this project because this is I've told all of you this is the only time in your training that you are actually being an advocate for your patient. And you're listening only with ears for them. And you're learning to listen, a skill that most people never ever learn in their entire life. This will actually help you in your personal relationships too. But not that it's helped me. But anyway, I would say, but wow, that was a total David Jabez kind of comment. Okay. Where's Paige? Sorry, I take it all back. Anyway, I think it's such an important thing, but I think it is something we could envision a very different way of doing these things if we had different tools and different skills. And then, the two together would be really amazing.
Yeah, it really would.
So remember, we're going to be tracking how much work you're doing for PSC. So, all right, thank you. Okay, and now we're talking about how to support your patients. We'll stay on that theme because patients need support in ways other than just their medical care. Sort of learning to listen to understand what's important to them as well.
All right, so for what I learned this year, I did think of this before Laura said status quo earlier, but the seed was probably planted last year when she said it. So I really learned to always challenge the status quo, no matter how many people tell you this is how we've done things, this is how we'll always do things. There's always a way to be more creative and make it better. So today I will be presenting on understanding the impact of career decision-making on the quality of life of young women with early stage breast cancer. So what if I told you that working more might actually improve a young woman's quality of life after an early stage breast cancer diagnosis, or if working more throughout treatment could reduce a patient's fear of recurrence? These were some of the questions we had at the beginning of my project. Can working more improve quality of life? How are patients planning for taking leave from work and planning for the impact on their career during treatment and diagnosis? Would our results from this project impact the way that we actually advise patients on taking leave and how to manage additional impact? But before I dive too far into this project, I want to take a step back and talk about breast cancer in young women. Breast cancer in young women can present differently and is associated with different treatment concerns than the more studied population of older patients. Young women present with more aggressive subtypes, have biology that's more likely to require chemotherapy, and ultimately have solely their age as an independent risk factor for recurrence. Their lives are in flux and they may be in a period of life when they're trying to find a partner or build a family or strengthen their career prospects or even increase their financial stability. All these unique factors make it extremely important to understand how we can uniquely best support this patient population. And maybe with young women, PSC is even more important because they have so much going on that having documentation and identifying those unique needs ahead of time can be even more helpful. But to be even more specific, given that young women may have less savings, less financial stability,
and are still building their careers, it is essential that we understand how breast cancer diagnoses and treatment impact their financial health, career trajectories, and their day-to-day work. Previous research has shown that 47% of patients experience financial decline due to treatment-related costs of breast cancer. The most cited breast cancer-related employment impact was taking paid or unpaid leave and experiencing job-related performance issues as a result. And prior research has also revealed that women who continue to work through treatment and recovery may have improved quality of life and lower levels of psychosocial distress. So relating these concerns back to some of the initial questions I posed, we turned to our Young Women's Registry here at the Breast Care Center. The Young Women's Registry, or the Young Women's Study, is a prospective study with the goal of better understanding breast cancer in young women. Our survey asks about topics like quality of life, fertility, family building, careers, and finances. Survey eligibility criteria includes patients who are female identifying and have been diagnosed with early stage breast cancer under the age of 45 years old. To meet our eligibility criteria for our survey, that diagnosis must have occurred in the previous 6 months before the consent. So how did we find these patients? We found eligible patients identified through weekly screening on Apex for new patient appointments with our medical oncologists at the BCC. Eligible patients were then reached out to by phone, completed consent through DocuSign, and then sent a survey using REDCap. So again, patients consented within 6 months of diagnosis, our baseline survey is sent, and then follow-up surveys are sent annually for 5 years to track progress over time. So to refine our aims for this project and to turn our questions into goals, we identified 2 main aims. The first was to understand how young women with early stage breast cancer plan for the impact of their diagnosis on their career and work. The second was to examine whether differences existed in the quality of life of patients who continued to work throughout diagnosis and treatment versus those who took some sort of leave, whether that be disability or medical. So we began with 262 eligible patients, and with those who were contacted and consented, we had 156 complete our baseline survey, and then a total of 73 complete our follow-up survey. And to get an idea of what this cohort looks like, the majority of our patients are white and they are working full-time. They have an income over $100,000 in their household. Most are diagnosed with stage 2 disease and have received chemo and surgery for their breast cancer. So as I said, an initial question we had was, how do baseline plans for leave as it pertains to career and work change after 1 year of treatment for breast cancer? So there's we had a lot of takeaways from this study, so I'm going to pick a few just for the sake of this presentation. So as you can see here, the majority of patients initially did plan to take some sort of leave. And what we found 1 year later is the amount of patients who actually took leave was much less than those who originally intended to. So maybe patients were able to actually continue working through treatment. Maybe they felt like they needed to because of the concerns that arise with the financial toll of treatment as well. Additionally, something that's really important to note here is the majority of our patients who take leave do want to return to work in their pre-diagnosis capacity. But what we found 1 year later is that only 75% of the patients who have returned to work are actually working at their pre-diagnosis capacity. So 1/4 of those patients are not working in the way that they originally wanted to return to after treatment. A couple of other comparisons to make. On this slide, you can see that at baseline, 57.7% of our patients were concerned about the cost of treatment as it relates to out of pocket or
co-pays or whatever that might be. However, after 1 year, that percentage does go down a little bit, but it still is worth noting that around half of our patients are still very concerned about the financial costs and the toll on their family's financial security, even 1 year after diagnosis. Another important thing to know is at baseline, a pretty significant portion of our patients are concerned about the negative impact of their diagnosis on their career. We are seeing most patients have this concern at least some of the time. And again, these are, observational data points at this time, so more analysis is required for significance. But after 1 year, we do see that only around 45.3% of patients actually reported that their career was impacted negatively. So again, we're seeing less patients that are taking leave, and then also patients who are having less of a negative impact on their career than they initially anticipated. So we also, as I mentioned, looked at the breakdown of the quality of life of our patients as well. And we assessed this using the PROMIS health measure system. And we had questions that asked about topics ranging from anxiety to depression to cognitive functioning, sleep disturbance, and we also utilized the Cancer Fear Recurrence Index. So in this first graph, we see the PROMIS domain specified on the x-axis and the T-score on the y-axis. And for reference, with PROMIS, a T-score of 50 is the mean for our sample population, and a difference of 10 points in a score represents one standard deviation. The higher a T-score, the more of something a patient has. So the more anxiety, the better cognitive functioning if they have a higher score. So here we can see that we're comparing baseline to our first follow-up 1 year later, and we actually don't see that much of a difference between the mean T-score of both our baseline and our follow-up population, which we might be hoping is, hoping to see more of a decrease in anxiety or depression or an increase in the cognitive functioning of these patients. And then we also wanted to look at the differences between the patients who ended up taking leave versus those who didn't. Again, here we're looking at the mean of the T-score in our populations. And here you can see that the patients who did not take leave have a pretty consistent higher score when it comes to anxiety and depression, and then pretty similar as it relates to cognitive functioning and sleep disturbance. To look at this a bit differently, Health Measures also has recommendations on the score cut points for patients' kind of severity of these domains. So they have a cut point that says, okay, if a T-score is higher than this, it's a moderate to severe level of anxiety. So here, looking at this data in a bit of a different way, we see that patients who didn't take leave have a much higher percentage of patients who are meeting that moderate to severe level of anxiety and depression, as well as sleep disturbance. So it could be worth noting here that, these patients were able to continue working, but it could have taken a toll on some of their quality of life domains as well. And then lastly, I mentioned we looked at the fear of recurrence in these patients. So again, here we're looking at patients who took leave versus no leave. And interestingly, so there's, with the fear of recurrence, there is again another cut point that denotes a clinically high fear of recurrence. And for patients who did take leave, 100% of our patients in our follow-up had a score that was considered a high fear of recurrence. Those who did not take leave only had 77.78% with that higher fear of recurrence score. This could suggest that maybe returning to work creates distraction. Maybe you're not thinking about recurrence as much 1 year later, but obviously this definitely requires some further analysis. So what are our takeaways here? So, one big thing we can say is how patients approach their work during diagnosis and treatment is impacting their quality of life. Our data suggests that not all patients who have taken leave initially are able to return to work in their pre-diagnosis capacity 1 year later. We also found that patients who did not take leave might be experiencing higher levels of anxiety and depression 1 year later, but may have less fear of recurrence. And lastly, we do also notice that patients are continuing to worry about the negative impacts of treatment and diagnosis on their careers, families, and finances, even 1 year out from their initial diagnosis. So obviously, we do have some next steps here. First, we really want to understand why patients aren't able to return to that pre-diagnosis capacity. What are the differences in quality of life between those that can return and those who haven't been able to? We also aim to increase our sample size and improve our variety of quality of life metrics we're assessing. Anna will soon talk about the ePro system that's been implemented in the iSpy trial, which has been able to seamlessly ask patients about quality of life symptoms on a very regular basis, with a very successful completion rate for some of the sites as well, which she will get into. But maybe there are lessons we can borrow from the way that ePros has been implemented as well. Additionally, we hope to look at other associations, possibly with demographic data like income or race or education levels, and see how that may also interact with the impact on career and finances. And with that, I want to say thank you, and hopefully this work will lead us to finding out how healthy work actually is for our patients. And wanted to end with Eliza and I getting capped for the first time, which Kelsey, it's coming your way. Yeah, thank you.
Good job. Yes, interns are required to do all kinds of roles. So do you think it would be actually of use to be able to present some of the information, even just letting people know that a year later, their quality of life is likely to be the same? Of course, you don't want to compare it to their cancer diagnosis, after cancer diagnosis quality of life, but yeah, I think that would be helpful to patients. What of this data do you think is useful to feed back to patients?
Yeah, I think it's helpful to figure out if really recommending leave is actually a helpful thing for most patients, or if continuing to work may lead them to not be thinking about recurrence as much. So kind of finding some more nuances there about who actually should be taking leave will be a really helpful next step.
And you mentioned the ePro system and iSpy. That might be a built-in way to extend this work, right? Because we have a lot of young patients. Yes, and probably a third of patients meet your definition of young. I don't think we're asking questions about work and return to work. But honestly, to the annual survey, one question, if you could come up with one question, my recommendation is we petition the ePro team. And go take this and make a presentation before you leave to the quality of life, John Rita and Don Hirschman's committee. You guys should make a pitch. And what's another advantage of doing it in iSpy? What's different about the population of UCSF versus iSpy?
Well, the UCSF population may not be as diverse as iSpy on a nationwide scale.
Yeah, because you have people from all over. I mean, we're really lucky the diversity. I mean, we have a really good diversity in the iSpy program. We actually have a rural and urban places too. So get your work cut out for you. Any other questions before we move on to the next? Thank you so much. Thank you. Fantastic, really. And speaking of ePro, and one source.
And one source, of course.
2020.
All right. Are we on my? Okay, so before I get started, well, first of all, I'm Anna. Nice to see everybody. I have two most important lessons I learned. I know we're supposed to have one, but the first is never make a joke about one source because it will follow you throughout your entire time here. And the second most important thing I learned is the power of curiosity. So if you ever think you've stumbled upon the correct answer or the best solution, that doesn't mean you should stop asking questions. Continue to ask questions because curiosity is what drives change. So without further ado, I'm going to be presenting today on the electronic patient-reported outcomes substudy of the I-SPY 2 trial. Throughout the course of my presentation, we're going to examine a few key questions to help us understand what patient-reported outcomes are, what our data is showing, and how we can improve our system. So we'll dive into this first question of why are we talking about patient-reported outcomes, and what does that even mean? To answer that question, let's take this example of a patient named Jane. Say Jane goes into the doctor and she asks for, or she's prescribed a drug treatment. And after she's prescribed this drug treatment, she's wondering, okay, well, what symptoms and side effects might I experience from this drug? In order to get an answer to this question, Jane consults adverse event information, which really means information about the symptoms and side effects associated with this drug. After consulting this information, she decides, okay, so I've concluded that patients typically experience X, Y, and Z when they take this drug as instructed. What Jane might not realize, however, is that current drug labeling practice for adverse events is based on the implicit assumption that an accurate portrait of patients' subjective experiences can be provided by clinician documentation alone. And while this might seem like a very subtle point to raise, it is an important one because a large body of evidence contradicts that assumption that clinician documentation alone provides an accurate portrait of what patients are actually experiencing as they move through drug treatment. Data show that clinicians systematically downgrade the severity of patient symptoms and that patients' self-reported data often include side effects that physicians have missed altogether, which can result in the occurrence of preventable adverse events. So how are we going to fill these gaps in our data? As I hope you might have guessed, this is where patient-reported outcomes come into play. Patient-reported outcomes refers to the prospective collection of data directly from patients about symptoms, side effects, and in our case, changes in quality of life that they experience while taking the drug. Patient-reported outcomes supplement traditional clinician adverse event reporting by enabling better documentation and identification of patient symptoms. And especially in the setting of clinical research where we're evaluating novel therapeutics, the ability to reliably collect and take action on patient-specific data is absolutely essential. So now that we have an understanding of what patient-reported outcomes are, let's move into how do we collect patient-reported outcomes in the I-SPY 2 trial, and what is our preliminary data showing us? Historically, we collected this information on paper-based surveys, which is exactly as you might imagine. A research member would hand a blank survey to a patient in the clinic, they would fill it out and return that piece of paper to their research staff. Well, that sounds like a very simple process. It's actually extremely cumbersome because the research members need to collect all of those pieces of paper, scan them into the computer, send them to a central coordinator who needs to extract the information from those scanned files and input it into a research database. As you might imagine, this data collection process is imprecise, the data transfer is error-prone, and importantly, it means that any analysis we want to do with the information we've collected is extremely delayed because of all the steps we need to go through in order to get it into our database. So what we've done is create an electronic patient-reported outcome system that we use in the I-SPY 2 trial. Within this system, research members need to enter a few key clinical dates into a single form on our computer. And then using those dates, our system automatically schedules all patient-reported outcome surveys for that patient to complete during treatment and follow-up. And whenever one of those surveys becomes available, an email is automatically generated and sent to the patient so they can click on the link, fill out the survey, and all of that information is automatically stored directly within our database. So cutting out a lot of those steps that we previously saw. We began piloting this at UCSF just about 2 years ago. And during the first 9 months, we found success with this platform. And our I-SPY coordinators will say there were a few bumps in the road, but we made it through. And in the second year, we rolled this out to all I-SPY 2 sites. And in that time, we have had 173 patients at all sites, plus 59 patients at UCSF, enroll on our ePros platform, or our electronic patient-reported outcomes platform. And one of the things we wanted to look at was how are sites doing in terms of completion rates? And we use those completion rates as a proxy for success. And so what we did was we divided sites into 3 different categories. And this is, again, completion rates we're showing on the x-axis here are our survey types, and then completion rate on the y-axis. And the groups that fell into this green category we're doing a good job of getting patients to fill out their surveys. The groups in the yellow category, which is for any of our colorblind audience members, oops. Well, we lost it now, but spoiler alert, what's ahead? All of the groups that fell into the yellow, we're doing an okay job of getting patients to fill out their surveys. And then finally, we had a group of sites that were not doing the best job of getting patients to fill out their surveys. And the reason we categorized sites like this was to be able to easily identify who we needed to provide extra training and support to and help sites integrate this into their clinic workflow. And a few of the things that went into our categorization were baseline survey completion rates, overall survey completion rates, and the frequency of patient engagement. Now, one of the reasons we chose to include baseline survey completion rates in this model was because we noticed that patients who completed the first survey that was sent to them were more likely to continue completing surveys throughout the course of their treatment and follow-up, as compared to the folks who didn't complete that first survey that was sent to them and had a little bit of a spottier completion record. And so once we saw that, we were wondering, okay, what's going on with this group that isn't completing as many surveys, and who are these patients? One of our hypotheses was that perhaps since we've moved to an electronic platform, maybe some of our older patients who might be a little bit less tech savvy are kind of struggling to adapt to the system. But when we analyzed completion rates by age, we actually found that the exact opposite was true. And after hearing Kaylee's presentation, this might not come as a surprise that some of the youngest women actually are completing surveys at the lowest rate, perhaps because they have childcare responsibilities or a number of other things going on in their lives. And not only did we want to focus on, okay, who are these patients who aren't filling out surveys, we wanted to ask, what can we learn from the patients that are filling out surveys? And we saw that patients who reported a higher level of social functioning at baseline were statistically more likely to complete a greater percentage of their total surveys over the course of treatment. And this was really interesting to us because, again, when we're thinking back to the data that Kaylee presented, maybe this means that we can use our baseline PRO surveys to help us predict who may need more support as they move throughout the course of treatment. And it also might help us, using the entirety of our patient-reported outcomes data, learn how we can support new recommendations to improve the quality of life of our patients as they move through treatment. And as I mentioned at the beginning of my presentation, we don't stop once we have a system that works. We continue to ask questions. And so that leads us to how can we improve our I-SPY 2 electronic patient-reported outcomes system? A few of the different things in the pipeline are we're providing site-specific reports, meaning we provide reports to sites showing exactly who's been filling out surveys so that they can quickly identify which patients they need to engage a little bit more with. And we're also providing iPads to be used in the clinic so that once they look at their site-specific report, they say, okay, my patient has a scheduled survey. Let me pull that up on the iPad and hand it to them in the clinic so they can complete it here. Some other things that are in the pipeline, we're really excited to announce that as of Wednesday, we have a Spanish language version that has gone live. So we can get more patients involved. And we're also hoping to return these results to patients, meaning once a patient submits a survey, it doesn't disappear into the ether. We're actually doing work to generate reports for them so they understand what have I been saying I felt 3 weeks ago and things of that nature. And finally, we worked with an awesome group of patient advocates to get a patient-facing brochure ready so patients understand exactly why this information is important, how it will be used, and why they should feel excited and encouraged to participate in this sub-study. And finally, we've been piloting the use of phone call reminders to patients. So for patients at UCSF in the follow-up phase, we're giving them a phone call to remind them to fill out their surveys, since it might have been a few months since they filled out the last one. And looking at all of these improvements and interventions that we have and are hoping to implement, it's important to return to the question of why we want to increase patient engagement with these surveys in the first place. And so we look back on these gaps that we were seeking to fill with our patient-reported outcomes data. And we can see that once we have this patient-reported outcomes data, we get a more complete understanding of what's going on with our patient as they move through treatment. And it also helps us understand what's going on at the site level and also the trial level. And when we have this more complete body of information, it helps enable a patient-centric learning health system. And what we mean by that is that we're able to collect data at the point of care, immediately access that data, and much quicker than with paper surveys, analyze that data so we can use it to support decision-making processes. So when we think back to Evan's presentation, that first presentation of the morning, and patients are deciding, do I want to pursue this treatment plan because I'm worried about certain types of toxicity? We now have a more full body of information that we can provide to that patient to help them make that informed decision. And the bottom line of all of this really is that once we have all of this incredible and complete information, it makes us feel confident that we are providing the right drug to the right patient at the right time. Thank you.
So great. It's so great to see this. Of course, I thought this was going to be done 10 years ago, but it just, never think about how hard it's going to be to get something done because you'll never get started. And that's, I think, really important. So have you done this presentation for the PRO group?
I have not.
I just texted, I'm leaving to make sure that you do. Okay.
Okay.
But I think this is, and you are writing this up
Yes.
before you start now.
No, Annika and I have a full paper draft and it's going to dawn soon.
Okay. Because I think it's just so important. And I think, again, Kevin is going to make sure that we get these up in the clinic as a routine. But I think that, again, all the assumptions you make about the older people, if I could tell you that 1,000 times people have said to me, you can't do this because older people won't use it. I mean, I'm just so excited to show that. To shut people up. Anyway, there's like 1,000 reasons why things can't be done. But I think one of the most important things about those, I noticed on the red group, there was like a line that went back up at the end. Was that after you showed them where they were compared to everybody else?
That's actually because since we're actively collecting data, the number of patients at each time point gets smaller and smaller. And so in that red group, they actually had 2 or 3 patients or whatever the number was that miraculously all completed the follow-up survey and had a very high rate of completion.
Have you actually taken this information and shown it systematically back to the sites?
Yes, we have.
To the PIs?
Not to the PIs. We're working on PIs now. We had a discussion about that.
And why is it important to show it to the PIs? With every site listed, of course, as anonymous except for theirs. Why is that important?
Because competition, fun and friendly competition drives improvement, I think.
Harness the natural competitiveness of this for good. Yes. Nikki. We don't know, but we hope so.
That's where we're going next.
We're trying to.
Yeah.
When we make it routine, I mean, that's part of this is a routine of care. So I think this is when you have a routine, where's Kaylee? Yeah, so like if all these tools were just a routine, which we are trying to make a routine here, so you can see that it's a routine, if it's a routine, and everyone gets in the hang of saying it, and where's Eliza? Okay, so if we have PROs, we have the checklist from physician. What do we need patients for? The physician's reps to be patient reps, right? Okay. Yeah, last question. Kim, not so challenging. Come now. Okay. How long have you lived with me? Really? Okay. All right. So question is, do these go back to pharma companies?
They absolutely should.
Yeah. So one of the reasons, so there's a reason you have, so a lot, when we showed the TDM1 was about the same as THP. So this is a much more patient friendly tool. When I went to Genentech, they said, well, we're not going to develop it for that market because the FDA will never approve something that's equivalent because it's less toxic. Is that true? No. But if you can't have any data that shows it's less toxic, they can't do it. So whose fault is that? Collectively, our fault. right? So one of the reasons why why is it so absolutely essential that we collect this PRO data? Teddy, Jayun, Evan, why? Why is the patient reported data and just an essential element of iSpy 2.2? We don't provide the data, they can't consider it. So, right, so we want to have combined endpoints. So like if you can get people to the OR after block A, and you skip, I mean, just skipping AC alone, I mean, you don't have to do any, you don't even need a PRO to say you're skipping AC, that's better. To the drug combination known fondly by patients as red death. You know, that is better. But again, even that, you have to present the data. If patients want what? Patients care about, what do you think do patients care about? Recurrence and toxicity, right? So and side effects. So they want both. But if we want to push both forward, we have to do the work. But when we make it a routine, it's not so hard. No? One sort. Okay. Awesome. All right, Ananya. Your break is a backwards, but anyway. All right.
Hello, everyone. I'm Ananya. And oh, yes, before we get started, the most important thing that I've learned. Oh, better? Yeah, okay. So I would say, Laura kind of touched on this just now, but I think the most important thing that I've learned is that sometimes you have to play the long game to make change. And the vision is what you start with, but there are often many steps between that vision and actually seeing it realized. Like Laura said, she thought eFlows would have been live 10 years ago. And so you have to do the work and put in the work and convince everybody to go on that journey with you so that your vision can be realized. And sometimes that's frustrating and takes a long time, but it's always worth it. So yeah, for my presentation here, we're going to shift gears a little bit, and I'm going to talk about UCSF and an affiliated hospital in the East Bay that caters to a very different population, and just talk a little bit about the relationship that we have with that institution, the differences between their patient population and ours, and about what that means and what we need to do about that from the perspective that we have. So here's a map of San Francisco and Oakland. And on the bottom left corner, you see UCSF, which is where we are right now, a place all of us are very familiar with and will become very familiar with soon. Just about 20 minutes away across the Bay Bridge is Highland Hospital, which is a community-based county hospital that serves a very different population. It's not far away, but the context couldn't be more different than the one that we see here. My role over the past 2 years at the BCC was to sort of be a bridge between these two institutions and to help realize the vision of Laura on the right and Dr. Khoury on the left, and to sort of bring to reality and bring access to the patients at Highland, all of the amazing things that we have going on here at the Breast Care Center. And what I wanted to use this talk was to open a window into this system for all of you, because we don't really get to see or hear much about Highland. And I think it's really important for us to think about as future doctors and future researchers and consider the importance of considering these diverse communities in the work that we do. So let's first talk about UCSF. So at UCSF, we have a very large program. Most of the data that I'm presenting today is patients between 2015 and 2020 that received chemotherapy at both of our institutions. So at UCSF in this window, we treated about 1,000 patients. Our program consists of 13 breast surgery providers, and that includes MDs, NPs, nurses. So 13 breast surgery providers, 18 medical oncology providers, 5 plastic surgery providers, 4 radiation oncologists, 10 radiologists, 4 pathologists, and so many more people. At the Breast Care Center, we're pioneering clinical trials, testing new imaging techniques, studying biological mechanisms, and developing predictive tools, all of which you've heard about from my colleagues thus far. And studying all of this and making use of all of this innovation, we're able to offer our patients the best possible care for their disease. And we're able to really tailor things so that they can achieve the best possible outcomes. Across the bridge at Highland Hospital, they have a much smaller program. So in the same window, they treated about 100 patients with chemotherapy. Their program consists of 2 breast surgery providers, 4 medical oncology providers, and 1 plastic surgery provider. And they also have a very important member of their team who's a non-clinical patient navigator. And this is really important because the patients there have a lot of unique barriers that we sometimes see here, but not with the same frequency that they do over there. So for example, 43% of their patients are not English speaking and don't have access to an English speaking family member. And you guys have seen how difficult it is to be a cancer patient. And now imagine going through that when you're not able to understand the information that's being given to you. Additionally, patients struggle with issues like food security, homelessness, drug dependency with a much higher rate than we see here at BCSF. And all of these things increase the complexity of their situation and impact their ability to receive care and be compliant. If you look at the populations at Highland and UCSF and compare the insurance status of patients there, at Highland, 0% of patients treated in the window that we looked at had private insurance. 71% were on Medicaid, 17% on Medicare, and the remaining patients were uninsured. In contrast, at UCSF, 0.3% of patients were uninsured, and majority of patients had private insurance or employer-provided insurance. And now this is not surprising given the fact that Highland is a county hospital and is meant for patients that are uninsured or underinsured. But this just highlights how different the 2 patient populations are and how important it is that we think about both as we innovate in medicine. If you look at race, the racial distributions at the 2 sites are also like polar opposites. If you look at Highland, 35% of the patients treated there were Black, 31% were Hispanic, 23% were Asian, and only 11% of patients treated at Highland were white. At UCSF, the trend was exactly reversed, with an overwhelming majority of patients being white, followed by Asian, Hispanic, and then Black patients. If we look at the stage at which patients presented with their breast cancer, the biggest difference is the proportion of stage 1 to stage 2 patients at these 2 sites. So if you look at Highland, 61% of patients presented with stage 2 cancer, whereas at UCSF, it was 41%. More patients here presented with stage 1 disease in comparison. Something that we maybe weren't expecting as much was the fact that stage 3 and 4 disease was actually higher at UCSF. But this may be because we receive a lot of outside referrals, so these severe cases could come from that pool. The important thing that I want to highlight here is that at Highland, 75% of patients fall into the stage 2 and 3 bucket, as opposed to 60% at UCSF. And the reason that I want to highlight this point is because, as you've heard about a lot thus far, we offer an innovative trial here called I-SPY that patients with more advanced and more severe diseases would really benefit from. And so these 75% of patients, because of their large tumors, would be eligible to screen for this trial. And additionally, we know that from a study done at UCSF in 2010, in a consecutive sample, 80% of cases at Highland were tumor grade 3, which means that not only do they present with larger disease, but also more biologically aggressive disease, meaning they're more likely to benefit from drug regimens like the ones tested in I-SPY. So this shows that patients in the Highland cohort have large tumors with more aggressive profiles, and thus far don't have access to opportunities like I-SPY. Their breast program does not run any clinical trials, and they have access to the standard of care and what their insurance will cover. And so the goal of being able to offer a trial like I-SPY to these patients is twofold. First, it's to increase representation of diverse groups in clinical research to ensure that the future of medicine is brighter for all people. So from the perspective of science and from the perspective of defining what the future looks like, it's very important that our findings are generalizable and not restricted to a small cohort of patients. We're trying to improve outcomes for everybody. And if we don't study how medicines affect everybody, we can't answer that question. And the second one is to help patients gain access to healthcare opportunities that will optimize their own personal outcomes. And this is a population of patients that has been historically and is still currently underserved. And it's very important for us to think about how we can serve them and leverage the relationship that we as an academic medical center have with this county hospital. And we have an opportunity to bring them forward. And so it's our duty to do what we can there. And so how do we get there? It's well and good to say we need to do this. I think that's obvious. But what are the barriers and what are the steps that we need to take in order to get there? So the first thing is that we need resources. Like, this is not an easy job. They don't have the infrastructure to support this trial right now. And so we need to figure out what they need and help them get it. We need coordination. We need people to actually help run the trial. And as our IFI coordinators can attest to, this is not an easy job. And we have a team of like 4 people here who are struggling to keep things afloat. So that is important. We need navigation because, like I talked about, there are a lot of like extra clinical factors that these patients have to think about. And if they don't have support in these areas, it's not possible for them to dedicate the energy to participate in such a rigorous trial. We need education, and that comes with translation, and it comes with building trust, because these communities have been historically marginalized, and it's really important that we are able to equip them with the information for them to participate and feel comfortable. And so what are the tools that we have in our arsenal? The first is the Berkeley Outpatient Center, which is the UCSF-affiliated clinic in the East Bay that has or will have in due time all of the capabilities to support this trial. And it's less than 10 minutes away from Highland, which makes it much easier for patients to access this care as opposed to coming into the city every week for treatment. Second is the California state bill that was passed in 2000 and amended in 2001, which states that any insurance company has to cover the cost of care for patients on a clinical trial, regardless of whether that care comes from an in-network or out-network provider, which enables patients to get care at the Berkeley Outpatient Center to be on the trial. And the final tool that we have is Quantum Leap, which is the I-SPY sponsor, which is extremely dedicated to increasing diversity in their trial and has the team and the resources to help us bring this to reality. And so what's next? First is to secure funding so we can help build out this program. The second is to identify and build the research infrastructure and hire the personnel to support this trial. And the last and most important thing is to mobilize the community so they can be agents in this process, taking control of their healthcare and feeling empowered in this process. I think this is really important work, and I'm excited for it to continue with the new interns that are going to be taking over this project. And I really want to thank all the people at Highland, at UCSF, and at the I-SPY trials who've been working on making this a reality.
Also something that's taken many, many years. Yes, and
Yeah, so
answer the S question.
oh, sorry. So the question was, why did we hypothesize the difference between stage and grade in the Highland population and UCSF? And one thing that I didn't mention was that historically underserved populations, particularly African American populations, generally present with higher grade disease. And like Paige and Jane and Teddy talked about, the stratification of these different types of biologies are not uniform in the population. And so to some degree, this is what we expect. And Dr. Esserman and I were also talking about earlier today that it would be interesting to look at the distribution of, for example, luminal Bs versus luminal As in this population too, because the graphs that Paige showed and the maps sort of corresponded with these regions as well. So I think that just in terms of the different populations that inhabit these two sites, that's the difference that we do expect. Also, I think often these patients are diagnosed later because they don't have as consistent medical care. So that may also contribute to the reason that they present with later stage disease.
But it is important to note that the stage is dependent on the biology. So who's in the I-SPY trial? What stage patient? 2 and 3. And, you know, we used to tell people, oh, you came in, you know, you neglected, blah, blah, and blame the patient, classic, you know. But in fact, it's about biology, bad biology. And there is something that I've never been able to put my finger on, but in the county hospitals in particular, and in places where there is stress, trauma, and pollution, there's a higher rate of grade 2. That's biology. That's not about neglect and care. I mean, there's hard to separate everything out, but they're not the same. And there's something about it. But the good news is that those are the things that are responsive to the new immunology. But you have to have follow-up because you get them adrenal insufficiency. So.
Yeah, and that's actually like a big part of what we're trying to figure out. So at Highland, like I mentioned, they have an amazing powerhouse non-clinical patient navigator. And the role that she plays is not a role that I've seen played for any of our patients here at UCSF, where she it helps patients be compliant with their medicines by literally like driving around the city and making sure they stick to their meds. And she sometimes like helps them secure meals when they're feeling sick and things like that. And so we're really working with her to try and design a questionnaire for patients to identify what the potential barriers are to participating in the trial so that we can understand what resources are needed to help them overcome those barriers. Because like we said, we've established that this is a really important problem, but solving it is not totally straightforward. And so it's really important that we understand the context so that we can bridge the gap in whatever way is required.
Last question is, when we were looking for funding, and we applied to a couple of these organizations that are designed to make sure to support better care for people who are traditionally underserved. The answer was, well, we don't support trials. What did you think about that reply?
Yeah, I thought that was a very narrow-minded reply because I think that by supporting the trial, you accelerate the advancement in all of the standard of care procedures that are required to support the trial as well. And having the trial is a really clear motivator for patients and for providers because it's an opportunity to improve outcomes in a population that may not have the best outcomes generally. And so by offering the trial or by pushing for the trial, you improve the infrastructure as a whole, and that improves care for everyone. And so I didn't find that to be a valid response from them.
Yeah, so that means that we will be pushing on them. We're just repackaging this presentation. Well, maybe before you go, we'll get Bob Ross on the phone and do this little presentation, and see what he has to say. So we can think about it a little bit differently. California endowment seat, yeah. It is, but I think it is also in today, honestly, in 2022. I think it's actually, I actually think there's sort of an unintended undertouch of racism. I mean, to say that somehow people who either, doesn't matter if you're Black, white, Hispanic, whatever, but if you don't have resources or you're down on your luck or whatever, that somehow you're not deserving of being in trial, or it's not worth the extra because it's so much extra effort that somehow you're not deserving. And I find that very offensive. So we will not survive arguing and allow that to exist. So with that, we're going to give you a 2-minute break. That's it. Stand up, 7-inch stretch. And then we're going to go to our next, when Rashda is going to be up next. Rashna.
All right, thank you. All right.
Rashna for all of our organizing.
Yeah, no problem. All right, hi everyone. We are in the home stretch, 5 more intern talks left. So now, I'll begin by saying one important thing that I learned this year is to just not take yourself so seriously or don't take anything too personally. You are an intern. You're gonna make mistakes. You know, there will be difficult moments, difficult patients, difficult physicians like Laura Esserman, you know. I'm kidding. No, I'm not. But the important thing is to, you know, don't take yourself seriously and just go with the flow. All right, so everything looks good on the Zoom? Okay, good. All right, so with that, I'm gonna start off with my presentation on changes in breast cancer screening practices and why it's really important to take a closer look at what's been going on in the past 5 years. All right, so all of us have some experience with being evaluated, whether that be report cards when we were little kids or now quarterly evaluations. We all know the importance of taking moments to pause and re-looking at our successes and our weaknesses. However, researchers like Ropers et al. In the paper below, they noticed that we don't really do this that much when it comes to health screenings. And why is it important to re-evaluate breast cancer screenings? Well, they have both benefits and harms. On the benefit side, we know breast screenings are incredibly important for early breast cancer detection. Yet we also want to be mindful of overscreening and the harms that can be associated with that, such as additional biopsies, fears, anxiety, and of course, costs as well.
So over the past decade, there have been changes in breast cancer screening technology, notably the emergence of 3D digital mammography, also known as digital breast tomosynthesis, or TOMO for short. And so 3D mammography is different from 2D mammography because 2D on the left typically just takes images from the front and the side of the breast, whereas 3D mammography takes many images of the breast from multiple different angles to really show the different layers of breast tissue. And so the goal of 3D mammography was, one, to improve cancer detection rates, and two, to also decrease recall rates. Recall meaning the number of times that a woman has to come back in for additional testing. And again, we want to reduce these rates because they can be associated with anxiety, cost, fear, things like that. And so the important thing to note was that in 2016, the United States Preventative Services Task Force stated that at this time, we can't really identify the benefits and harms of 3D. We need more data. So a year later, the NCI-funded TMIS trial begins. And it's the first large trial looking at 2D versus 3D mammography. And although the results of the TMIS trial are not out yet, here at UCSF, we wanted to know what was happening in the real world. And so we partnered with Optum Labs and we looked at claims from a large national insurer. And what we found was that there is this huge uptake in 3D mammography in the past 5 years. Here we're looking at screening mammography. We can see that between 2016 and 2020, screening mammography increased, 3D screening mammography increased by about 59%. Likewise, again, we see a huge increase in 3D diagnostic mammography as well, from 29% in 2016 to 77% in 2020. So the next question we asked was, did 3D mammography accomplish its goals? Did it really reduce the recall rates? And we can see here, looking at 2019 data, about a 1% decrease in recall rates. We were really expecting for maybe less than 10%. And why? Well, when we look at recall rates across the world, like the UK at 7%, Sweden at 3%, we have a lot of room for improvement, and they still have comparable cancer detection rates. So takeaways so far, we've seen a replacement of 2D with 3D, and we've seen that 3D in real world data is still associated with high recall rates in the United States. The next thing we asked were recall rates high throughout the United States? Or were there certain regions within the US where recall rates are high? And we noticed that there are 3 states, New York, New Jersey, and Connecticut, where in addition to being early adopters of 3D mammography, had high recall rates, and were also using screening ultrasound at 10 times the rate of the rest of the United States. And so just for a little bit of background, screening ultrasound, it's not really a primary screening method. It's really used in conjunction with mammography in the setting of dense breast tissue. And so we wondered, okay, what could cause these 3 Northeast states to be using screening ultrasound so much more than the rest of the United States? And when we looked at policies and legislation that was enacted in the past 5 years, we saw a little bit more of the story. Within the past 5 years, these states passed legislation that required women to be notified if they have dense breast tissue. Note, about 50% of women have dense breast tissue. And it required insurance companies to fully cover the cost of supplemental screening, such as ultrasound. So our hypothesis is, if you tell someone they're at an elevated risk for breast cancer because of their dense breast tissue, they're going to feel anxious. Clinicians and patients are going to feel worried, like mammography isn't good enough. What is available? Screening ultrasound. And insurance is going to cover it. We're going to administer it. So this is just a finding that reminds us of the impacts that policy has on clinical practice. And why do we care about screening ultrasound? Well, like I already mentioned, it's not the best primary method. When we look at recall rates with and without ultrasound, screening ultrasound, it doubles recall rates, it triples biopsy rates, and it doubles cancer detection rates. And one thing that we have to do internally is look back and see, what is all this cancer that we're detecting? Is it invasive breast cancer or is it DCIS? Is it slow growing or is it fast growing? So that's another step that we have to do. Again, bringing it back to why is this important? Why are we looking at screening trends? As pre-medical students, you all know the golden rule of, do no harm. And so, like I mentioned at the beginning of my talk, screenings are related with anxiety, especially recall rates and getting called back for further testing. This woman says that when she was called back for a second mammogram, she thought it was, she was afraid it was cancer. It was all she could think about, viewed it as a death sentence. And of course, one thing that I haven't talked about too much in this talk, but is a completely separate talk, is all the costs involved with new technology and diagnostic workup. This patient said she still paid $1,700 because her original no-cost mammogram led to an ultrasound, another mammogram, and an MRI. So in summary, really just want to reiterate that screening tools, practices, and policies need to be frequently reassessed. Why? In order to prevent doing excess harm. And I will just end with a quick quote from Mark Twain. He says, "Success is a journey, not a destination. It requires constant effort, vigilance, and reevaluation." So I want to very quickly thank everyone on my project team, especially Kim in the room and Jim on Optum. And then of course, my big thank you is to my Athena Wisdom team, my mentor, Allison Fiscalini, everyone that I've written down on this slide. Apologies if I forgot you, and especially to the interns for being my role models and my support system for the past 2 years. Thank you.
So great job. So how is it that you think that the UK and Sweden have such low recall rates and yet have the same cancer detection rate?
I think it's multifaceted. One, I think, is a cultural issue in the United States. We are really set to thinking doing more is doing better. And we forget that doing more can sometimes, end up being worse. On the other hand, like I mentioned, we also see policies, such as the ultrasound one, that can facilitate additional testing.
Unintended consequences of doing more. And actually, it's very interesting. During the senior retreat that my husband used to work in the Capitol, and they were trying to pass this bill, which we were trying to stop. I was trying to stop from the notification of the dense breast issue for this very reason, which we weren't able to stop it, but we were able to stop the requirement for the ultrasound coverage. And I'm going to go back to the authors of the bill and send them out or the paper.
Okay.
And when that $1,700 with the MRI, again, screening's supposed to be covered, completely covered, no copay. Anybody know what the cost of the MRI biopsy is? An MRI, if they had recommended an MRI biopsy.
Oh, I have biopsy alone.
The biopsy alone is.
Yeah, we looked at commercial rates for biopsies alone, and the median was $2,700.
And an MRI guided biopsy is actually BCC the charge. Retail, $20,000. How many of you have insurance? Now, what's your copay? What's your copay for procedure? Better read the fine line here, and ask whether you really need a procedure. What is it? Anybody know? What do you pay for your copay? Well, that's for a visit. What about for procedures, radiology? Anybody know? 20%. Unless it's out of network there, so 20%. So what would that be?
Money.
$4,000.
Yeah.
So that's why, Ananya, on the website, we have to have what is it with the calculator for what the imaging costs are. People are just unaware. The radiologists are completely unaware. And someone says, "Oh, let's just do it. What's the harm of doing an MRI biopsy?" I said, "Well, she's a teacher. $4,000 is her copay." She had no idea that it cost $20,000. So it's important to know. Okay. Yeah.
Yes. Right, right. Yeah, that's a great question. So the question in the room was, there are other states on the map that I showed that also had similar legislation enacted. And we don't know the full story, but one guess is that, the Northeast, in addition to using ultrasound, were early adopters of 3D mammograms. So it's possible that an ultrasound. So it's possible that in other states, they weren't adopting these changes in practice as fast. One estimate, we're not 100% sure, but possible.
The other is how many, let's see, let's have the New Yorkers raise their hand. Who's from New York? Who's lived in New York?
Mentality.
Okay, yeah. Very anxious and very aggressive.
Right.
Right. So it's like, do more. I mean, but the culture of doing stuff like all the time, right?
Right.
So it's like once it's out of the bag, and also what's the ratio? We should also plot the ratio of physicians to patients in each of these places. The Dartmouth Atlas of Healthcare shows that the higher the ratio of physicians, the more. Yeah. Okay. Sure. Value-based care. Yes.
Right. Yeah. Yeah. So the question was, well, there's someone from the Northeast, so and relates to the mentality of being extra aggressive. And what what can we do? Well, I think the first thing to do is really to get this data out there, because as Laura often says, you can only do better if you know better. So it's really important that we disseminate this information, so that way providers, hopefully in the Northeast, will start taking a closer look at their approach.
And I think people think they're doing the right thing. It's Eli Shea, who's now there. He says, like, doesn't matter when he writes, the ultrasound gets done, even if he says, do not do an ultrasound. But if someone is at high risk, truly at high risk, and has dense breast, extremely dense breast tissue, what's the right test?
MRI.
Correct. Some kind of contrast, either contrast metal or contrast MR, not ultrasound. People aren't aware of this huge false positive, we call it. That is just nonsense. It's a good diagnostic test. It's not a good screening test. It has never been a good screening test. And this is the thing, that people just like do stuff without any, again, you are no better than someone who's selling Lakeville, or, Apricot kits or whatever. It is like, if everything doesn't matter, just, that's the same thing people say, I'm following the pathway and I'm giving this drug. That is like, demand the evidence. Even God has to bring data. Okay, so I used to say, in God we trust, all others bring data, but in fact, everyone does that. All right, we're gonna move on. Thank you so much. Move on to the wisdom study.
Thank you, Laura. So I'll start with the two things that I learned. I couldn't choose one. I think the first thing that I've learned is don't start with the reasons why you can't do something. Start with the reasons why you can. And then also don't let perfection be the enemy of good, which I've learned that from you, Laura. I know. I really internalized it this year. So my presentation builds off of Rashna's and looks at the Wisdom Cancer Registry linkages and sort of reports on this procedural study that we have done over the past year. So a quick background on the Wisdom study. So it's a pragmatic trial aiming to enroll 100,000 women across the United States And a primary goal of the trial is to assess a non-inferiority of personalized versus annual screening by comparing the rate of advanced cancers, which we define as stage 2B or higher. And to assess this goal, we really need to understand the exact number of on-study breast cancer diagnoses that have occurred to properly assess this outcome. So how do we normally collect this data? So up until this point, we have collected, if a Wisdom participant is diagnosed with cancer, they report this to the Wisdom study by either filling out an online questionnaire or contacting a study coordinator. But there are obvious challenges that exist to this process, namely that Wisdom is a very large cohort. And as we have talked about in the previous presentations, self-reported data is not always complete and participants don't always fill out questionnaires. And then secondly, there's a relatively low incidence of advanced breast cancer in particular. So we really need to hit this number as closely as possible. And so to do this, we need to validate these endpoints through other means. So this sort of is what is the impetus for my project. So our project has two main objectives. The first is to verify Wisdom self-reported diagnoses, and then also find diagnoses that were not previously self-reported to Wisdom that are essentially missing in our data set. And this will enable us to verify study endpoints, assess a non-inferiority, and then also assess safety measures in real time for our biannual data safety and monitoring board meetings. So how did we do this? So to ensure the accuracy of the Wisdom cancer data set, we looked at 4 data sources, including the UCSF Cancer Registry, the UC Data Warehouse, the California Cancer Registry, and then we are hoping to use the North American Cancer Registry in the future. There are various advantages and disadvantages of these data registries and warehouses, and that is why it's so important to use multiple sources. And the advantages and disadvantages can kind of be combined into 3 separate categories. The first is the accuracy of the data within the data warehouse. So how can you use it at face value, or does it need additional verification? The second is how large the cohort is that's represented in the data source. So is it a specific site? Is it state or even national? And then the last is the timing of data completeness. So how long does it take if a woman is diagnosed for her cancer to show up in a given data source? So this figure is busy and I won't go into it completely, but the 3 main points I want you to take away are boxed in blue. The first is that if green sort of represents an advantage and red represents a disadvantage, as you can see, there are these no source is perfect, no source is all green or all red. And so working together to use these various sources enables us to best verify these study endpoints. As you can see in the State Cancer Registry, the second column from the end, this has a very good data accuracy and has a wide geographic reach, but it can take up to 2 years for this data source to be complete, necessitating, especially given that we want to assess these endpoints in real time, to use other sources. So as you can see in the UC Data Warehouse, the coding accuracy isn't always perfect. However, the data completion is much quicker, in less than 6 months. And so this allows us to best analyze study endpoints in real time. So this is sort of our first result section, one of the most important questions that our study aimed to answer, of how many Wisdom cancer cases were uncovered through these various registry linkages. And as you can see in this table, there was some overlap between the registries, so they identified similar cases, but the unique number of cancer cases was 48, which represents approximately 11% of the overall Wisdom cancer data set. So I think this tells 2 stories. First of all, these registry linkages were valuable as they did add a sizable number of cancer cases to the overall Wisdom data set, but also self-reported data is pretty good. We only missed approximately 11% of the cancer cases. The second question that I think is really important is, of these cancer cases that we missed, what were the stage of them? Because as I mentioned previously, stage 2B or higher cancers are the ones that we're really interested in making sure we've gotten all of them. So as you can see, the takeaway here is that most of the cancers were early stage cancers, which I think is a good sign that we're not missing too many advanced cancers in our data set currently. And then lastly, what was the time of these diagnoses of these unreported cancer cases? And I think this points to the utility of the UC data warehouse in particular. So these are unique cancer diagnoses found, and we analyzed them in sequential order in the way that they were listed. But as you can see that the UC data warehouse on the third line gave us a lot of diagnoses that were post June of 2020. And why I use this date is because, as I mentioned previously, the California Cancer Registry oftentimes has data that's not complete for up to 2 years. So as we can see, the UC data warehouse provides a significant value add for these post-June 2020 cases, which sort of supports using this data source moving forward. However, the California Cancer Registry still does provide value, especially in those cases before June of 2020, and I think is important to think about as well. So on the flip side, sort of why would we not just use the UC data warehouse then if it's providing all of these cases in real time? And I think this is our flow diagram and sample process. I won't go into this in depth, but I wanted to take out a specific part of this flow diagram and focus on those wisdom participants that were found in the UC data warehouse that had a C50 code, which codes for a breast cancer diagnosis. And of these people, 47 of those, we did not have a reported cancer diagnosis in wisdom. And through manual chart review by site coordinators, we found that of those 47 people, 22 were verified to be diagnosed, but 20 we could not confirm that they were diagnosed, representing that you can't take EHR data as fact, and additional verification is needed if you want to be as accurate as possible. So I think my project has, so in conclusion, there are 48 cancer cases that were uncovered in wisdom, encompassing 11% of wisdom's cancer diagnoses. Most of these cancers were early stage, and the date of diagnosis varied by data source, demonstrating that each data registry has different limitations and benefits. And so working in conjunction with all of these will best enable us to verify wisdom's study endpoints. The limitations, we have only analyzed the California cancer cases, so we hope to expand this study nationally, given that wisdom is a nationally recruiting trial. And then my takeaways, I think there is a story to tell on both sides that wisdom self-reported data is relatively accurate. However, we also need to supplement it with other means. And verifying wisdom study endpoints likely requires several methods because of the benefits and drawbacks of each source that I mentioned previously. And then lastly, I think the next steps of this project, we need to understand that EHR data is not always fact. And we might consider, can there be greater oversight in how this data goes in the first place? And think about the mismatch of the design of the EHR and thinking about more of the billing roles versus its use in clinical care and also research, and considering solutions such as OneSource to make clinical data more usable for clinical care and research, and thinking about how we can best improve this accuracy of the data. And I'd like to thank all my mentors and all the BCC interns for a great year.
Everyone's putting it on the slide, so I can't even ask about it. But I think, didn't someone have on one of the skits a OneSource bingo card? But I think it is, again, but that just points out again, right? So who needs that data? Who needs accurate data besides the registries?
I mean, everyone does, clinicians, researchers. So yeah, I think it has a lot of implications across all projects.
Why not just get it right? And wouldn't that just make your life so much easier?
It would.
Just think about it. So this is motivation. Just think, I mean, really think about it. I mean, in the future, when you're running studies or trying to do things, imagine if the data were at your fingertips. What percentage of your effort now is gathering data versus analyzing data? What's your ratio?
Good question. A lot more at gathering data than analyzing it.
And what should it really be?
A lot more analyzing.
Yeah. So that's a future that we can all aspire to. But it is, you know, it's interesting that our data safety monitoring board said to us, you know, that this work that we're doing might be the most important finding of the entire study and sort of showing people how pragmatic studies can be done, what the quality of the data is, how it should be. And it actually, I wouldn't be surprised. I mean, it's really, because there, you know, I mean, if we could only get the data. But it is.
We need to develop a similar process for the members.
We do, I know, wouldn't it be? I mean, I think that is possible. Yeah. All right, aren't you? Yeah. So this is, if we can use the Apple Health Kit to pull that mammogram report. Wow,
Be
that would be a
amazing.
game changer, right? So that's our next step. Yes, question.
So the question is, who's the patient population who's not self-reporting the data or who we're uncovering through the registries? It's a really great question. We actually have analyzed it and we're not able to find any real difference between the overall wisdom population and the people who aren't self-reporting it. I think that shows that we aren't systematically missing anyone, which is great. But I think, yeah, we can find any conclusions. So I think it's a promising thing, but also makes it a little bit harder to potentially address because it does seem to be a bit random. Yeah. Yeah. Yeah, that's a really great question. I mean, I think it speaks to the question was how could this work be influenced in thinking about patient-reported outcomes more broadly, and how we assess this. I think it speaks to the quality of the wisdom workflow that we are getting most of this data. And so I think that there's a lot of takeaways from that. And I also think, but I also think it shows too that these patient-reported outcomes do, or I guess patient-reported data does need to hopefully be assessed by other means as well.
All this needs to be made more standard.
Exactly.
Okay, great, fantastic. 3 more fantastic presentations coming up. Next up is Christian, who's going to talk to us about DCIS.
Okay, hi everyone. My name is Christian. I'll start off with the most important thing that I've learned, and that's being persistent and being decisive. When working through a project and trying to get it through point A to B and C, you need to push yourself, push others, and never take no as an answer. Okay, so with that being said, today I'll be presenting on active surveillance and how we can use MRI features to help predict risk. So first, what is ductal carcinoma in situ, or DCIS? More formally, DCIS is known as the presence of carcinoma cells within the ducts that have not invaded past the basement membrane into the surrounding tissue. So if you look to your right, you can see an image of a breast. Within that breast, there are lobules and ducts. Those lobules create milk, and those ducts carry that milk to the nipple. So DCIS is essentially the presence of those abnormal cells within those ducts, and remember, they're confined. Current treatment for this involves surgical excision, endocrine therapy, and or radiation. So now let's talk about the overtreatment in DCIS. So when you look to the right, you can see a graph. Within that graph, on the y-axis, you can see the number of cases being diagnosed, and on the x-axis, you can see time in years. At the advent of screening mammography, you can see that DCIS is being more aggressively diagnosed. And as Roshna kind of spoke about earlier, sometimes overdiagnosis has consequences, and this means more biopsies and more surgeries. And this is important because not all DCIS will progress to invasive cancer if left untreated. So this leads us to believe that surgical excision may actually constitute as overtreatment in some cases of DCIS. So how can we address the overtreatment in DCIS? Well, one way is by offering a diverse set of treatment options that help risk stratify patients. So here I'll talk about the different treatment pathways for DCIS at UCSF. We have the standard of care treatment pathway, which is surgery, endocrine therapy, and radiation. You should see now the high risk pathway, which includes the immunotherapy trial, and Nikki will talk about that later. And now you should see our low risk pathway, which includes active surveillance, and that's what we're talking about right now. So what is active surveillance? Active surveillance is a treatment plan that monitors DCIS for progression with no surgical excision. And so we monitor these patients with MRI scans and or mammograms, and these patients are often on endocrine therapy. Right now, we have right now there are three significant phase 3 trials for active surveillance, and these are COMET, LORIS, and LORD. So let's dive into our UCSF cohort. So in this diagram, you'll see how we chose our patients. So there are 190 cases of DCIS enrolled into neoadjuvant endocrine studies. 127 of those cases were excluded for various reasons, and this could be having less than 2 MRI scans, being lost to follow-up, not being on endocrine therapy, and also being on studies that mandated surgery. And so that leaves us with 63 cases of DCIS that are truly on active surveillance with endocrine therapy. Here are our clinical outcomes. So starting from the top with our 63 cases, 32 of them are still on active surveillance. 31 of them went to surgery. Of the 31 that went to surgery, 15 had DCIS upon surgery, and 16 had invasive cancer. And it's also important to note here that the mean time on active surveillance is 4.9 years. So, and this now brings us to our main question: how can we predict which DCIS lesions will progress into IDC? We can use MRI features to help us do this. So we had our radiologists answer questions about MRI features for multiple MRI scans for each patient. Here are the features that we asked them to evaluate, and they're listed down below. And the most important ones were lesion distinctness and background parenchymal enhancement, or BPE. So now let me briefly explain the different categorizations of BPE, or background parenchymal enhancement. A is minimal, B is mild, C is moderate, and D is marked. BPE is the presence of enhancement within the breast. And you can kind of see in D how cloudy it is and how it can obscure the tissue that you see on MRI scans. Next, let me explain what a distinct lesion is. So a distinct lesion is a defined area of enhancement that stands above the surrounding tissue and BPE. And here within the red box, you can see a lesion that stands out from its surrounding tissue. So for our risk stratification analysis, we used in our part recursive partitioning algorithm that incorporated baseline MRI features that our radiologists gave us to optimally classify which patients may progress to invasive cancer. So this algorithm took in different MRI features and then split patients into different subpopulations. The result from this algorithm showed us that lesion distinctness and absolute BPE were important in distinguishing 3 groups: low A being the lowest group, the lowest risk group, low B being the second lowest risk group, and then high being the highest risk group. So now on this slide, you can see a plot where we mapped the results given to us by the algorithm, and then also some additional MRI features. This plot gives us the ability to see how these MRI features separate into each of these different risk groups. So the highest risk group is at the top, low B, which is the second lowest risk group, is in the middle, and then low A, which is the lowest risk group, is at the bottom. And as you can see here, each row denotes a case of DCIS. And then on the x-axis, you can see that this is being mapped out at different MRI scan time points. So 0 being the baseline, 1 being the second MRI scan, 2 being the subsequent, and so on. And so when we look at the 3 columns just on the left portion of this plot, there are 3 different types of shapes. So the diamond shapes reflect the different types of lesion distinctness. The squares reflect the different types of BPE. And then the circles, if they're present, mean that the patients went to surgery. It's important to note here that the red circles mean that the patients went to surgery and had invasive cancer. The orange circles mean that the patients went to surgery and had DCIS. And if there are no circles present, that means that these patients are still on active surveillance. And then another thing to mention here is that we also map the change in lesion over time and between each MRI point. And you can see that by those bars within the plot. Green meaning that the lesion regressed, blue meaning that the lesion is stable, and red meaning that the lesion progressed. So a few main takeaways from this plot is that there's a higher rate of invasive progression. So those red circles in the high group, the grouping of distinct lesion, those pink squares, and distinct lesion, those brown diamonds, and then minimal BPE, those pink squares, they're enriched within the high risk group. Marked BPE, which is those brown squares, is not enriched within the high group. And mild, moderate, and marked BPE is enriched within the low A and low B groups, and those are denoted by the blue, purple, and brown squares. Another thing here to mention is that if we look closely to the high group, these patients were on active surveillance for roughly around 6+ months, and we were able to denote when these lesions were progressing. So now for my final remark. So for the conclusions, imaging over time can give us insight into the biology of hormone-positive DCIS. DCIS is not invasive cancer, and for our next steps, we need to validate these MRI imaging features in future cohorts, then also potentially correlate pathological features with MRI features to help risk stratify patients. Many thanks to all these people. I believe in having a chosen family. And so after these 2 years, all my mentors and fellow interns, I appreciate you all. And I think of you as my chosen family, and I don't take no as an answer. So.
I go back on what I said to you during the presentation. I'm looking here because this is actually for Elissa too, looking at this. So most of the information is when do we get most of the information at this meeting?
So at baseline, and then at the second MRI scan, and potentially the third as well. So within the first 6 months.
Yeah, and I would say probably 75. It'd be worth looking at, how many people change classification from 3 to 6 months. I think some do, probably another 10. I'm just trying to count up, but then you're done. Anyway, but I think it's, but I think that's the point. Can you, that's probably the next thing we need to look at. I think before you go on those patients, let's look at the background and stuff. Just using this simple algorithm. Because it's pretty easy. Background, we don't have to make it so simple. Then you can look at the background to the lesion, that these same kinds of things. It's so striking, right? I mean, it's so simple, and you don't need like anything terribly fancy to look at it, but it's so striking. I think it's worth really looking at. But these early endpoints allow what? They allow you to.
They allow us to see, I guess, risk stratified patients, see which patients perhaps should go and have surgery, and which patients may be amenable to endocrine therapy as a risk reducing therapy.
The question is, what is low A and what is low B?
Yeah, the biggest difference here is that in low B, you can see that they're all essentially distinct lesions, and in low A, there are no distinct lesions. And within both of these groups, they have, I guess, essentially all the different types of BPE: minimal, mild, moderate, and marked. And that gives us a little bit insight into them, in the sense that there may be some aspect of their tissue or their
I guess, tumor microenvironment that we can control with endocrine therapy or hormone therapy.
And so they both have very low risk. Yeah, they're both, if you can control them, if there is no focal lesion and your background gets better, is there any reason for surgery?
With no focal lesion?
Yeah.
Nope.
Yeah, what exactly are you doing? Just because we've always done it does not mean, right, that we should do it. So, right, and then if you have a focal lesion that goes away, the background goes away. Right, so, yeah, so it's just a way of trying to figure out the age-old question, does everyone need an operation? And, probably not.
Mhm.
Yeah, yeah.
Mhm.
So the question is, what is BPE?
Yeah, so BP is essentially the presence of enhancement after the uptake of contrast. And this could be attributed to a few different things. This is also something we're investigating, but it could be cell leakiness, increased, microvessels within the breast tissue, and also potentially things like BCIS density.
So BPE is actually, so again, it's your timing. So when you give contrast, if there's a focal lesion, the rate of contrast uptake can wash out. That is actually, that's a poor man's way of looking at grade, right? So the signal enhancement ratio for the people who are doing I-SPY, that's another factor we can look at. But we looked biologically many years ago at this, and background, it's that gradual uptake over time. And MRI is really just looking at vascular uptake and washout into the parenchyma. And so it tracks with the vessel density, whether or not cells are turning over P67 rates, so CD34 counts, P67 rates. And so so-called false positives, it's not false positive, you're just looking at very slow uptake really is associated with areas of high cell turnover, vascularity, and probably inflammation. Those are the things that's you can't tell the difference if someone has a big infection or granulomatous disease. You can't tell the difference because it comes up too, but except that you have late uptake. So it's actually it's a perfect biomarker. And so that you're actually directly looking at the microenvironment. So the microenvironment, it's this data that makes me think that might be one of the best markers for the EOP. But the two together might be, particularly important. So that's the next. You have time to eat it before you go. Good. Moving right along to the high grade DCIS, because all DCIS are not created equal.
Hi, happy Friday. I'm Nikki. I am the second half of the dynamic DCIS duo. And I'll start out with my valuable learned lesson, which is the biggest risk is not taking one, whether that be in clinical trials or theater or writing your skits, just keep that in mind. Oh, am I too loud? You don't want me writing. So today I wanted to talk to you guys about how we're treating high-risk DCIS using immunotherapy. And I think we've been looking at lots of big numbers with clinical trials, but I wanted to look at it on a more granular level and look at a couple patients on this study and what we've learned so far, and how the water can sometimes be a little murky when you're looking at individual patients in the context of like a whole clinical study. So I love going after Christian because he always does such a wonderful job introducing this. But we just heard about how DCIS is not one size fits all. There are different risk stratification within that. And so we heard about what we're doing for cases of DCIS that are lower risk, hormone receptor positive, low grade cases. Those are women who are going on our active surveillance trial. But what about these cases of higher risk DCIS that shouldn't be watched? They should probably, we need to be doing something for them. And is there a more effective and less invasive way to treat them in a more individualized context that's not just going straight to the operation room? So I want to start out talking a little bit about the tumor immune microenvironment. And this is some work that's been done over the last decade, specifically the link between having high tumor infiltrating lymphocytes or kills. So those are things like T cells, different immune cells around your tumor and having a more favorable prognosis. And this is something we've seen in multiple different solid tumor types, including early stage breast cancers. And work that came out of the Campbell lab in 2017 is that high grade DCIS is correlated with having higher percentages of these TILs, infiltrating lymphocytes. And you can see that in this heat map here, things like having high tumor size, high grade are correlated with having the higher TILs. And so with this information combined, can we mobilize the immune microenvironment in these women with high grade, high risk DCIS lesions and maybe prevent possible progression and prevent recurrence down the line? So the way we want to do that is using immunotherapy for women who have these high risk DCIS cases. And they're characterized as being high risk, having two of these, or at least two of the following characteristics, being HER2 positive, hormone receptor negative, high grade or young age, large size, any of these things. So what we did was design a study where women would receive 2 to 4 low dose local injections of immunotherapy directly into their DCIS, followed by surgical resection. And the immunotherapy that we're giving is called Keytruda, which is used, the PD-1 inhibitor used in early stage breast cancers as well. The thinking being that in women who have these DCIS lesions, we can use this immunotherapy to recruit immune cells into the DCIS and help resolve the lesion. And actually what we found is that these are immunohistochemical images. Down here on the left, you can see the pre-treatment image, the yellow cells being the DCIS cells. You can see kind of an empty region around there, not much going on. And then on the right side here, you can see a post-treatment image from a woman who received these injections, these purple and green cells being T cells. So you can see that after the injection, we have this, increase in the immune infiltrate. However, we treated 14 patients with these pembrolizumab injections. And overall, we did see an increase in immune infiltrate in some of the patients, but overall, there was no change in the MRI volume and no change in the number of tumor cells in these patients. So we had some encouraging data, but it wasn't enough. So we thought, what can we do? So we added this mRNA drug made by Moderna, which is a T cell co-stimulator and a pro-inflammatory cytokinase. Lots of big words, but the thought was to just, it's not enough to just have the immune cells there. We need to mobilize them. They need to be in action. So we kept the same trial design, but we added this drug. And so far we've treated 2 patients. The first patient, she presented with hormone receptor positive disease, HER2 negative. And we actually looked at her tissue in the same type of multiplex assay, and she really didn't have that much immune infiltrate around her DCIS before treatment. And so she received an injection. Afterwards, we didn't see any change in her MRI, no change in immune infiltrate, and no change in the number of DCIS cells. So we're kind of back to square one there, kind of the same as just the pembrolizumab alone. So we treated another patient. This patient had hormone receptor negative, HER2 positive disease with some microinvasion in her biopsy. And you can see here, this is her pre-treatment multiplex. And once again, the yellow is the DCIS. You can kind of see the duct structure with all the DCIS cells inside. And then the green and purple around are all T cells. So even before she even received the injection, she had this primed environment. And what we saw with her is after she received the injections, we saw a small change in her MRI, small reduction in the size of her DCIS. And interestingly, we saw high infiltrate in some areas of her biopsy, but we actually saw no residual DCIS left in her biopsy, which is really interesting. And you have on the left there, you can see the yellow dots, and inside there's actually just calcification. So there's no real DCIS cells. And on this side, you can just kind of see some more normal looking ducts with a little bit of infiltrate around. So this is all interesting and a little bit confusing and kind of what the trial looks like going through it. Like you have the whole design, but then you also just have individual patients and it's like, okay, great, this worked, but why did it work? And can we replicate that in another patient moving forward? And is having this immune infiltrate prior to even receiving the injections, is that something that can predict someone being a good responder? And really the only way we can know that for sure is to put more patients on study, which we're doing. But yeah, is it dependent upon this pre-existing immune infiltrate? So thank you so much to all of my mentors and all of the lovely interns. I'll miss you guys all so much.
Very exciting. And by the way, everyone make sure that Anne-Marie has a copy of the slides. I'm gonna post them and have them up. It's really great. Do you think we should be offering this vaccine to people who don't have T-cell infiltrates, or do you not know?
It's hard to know 100% for sure now, but one of the things that I should mention is also women do get sick who receive the injection. So they're sick for a couple of days. It's not the same as getting full-blown chemotherapy, but you're still, experiencing fever. You don't feel very well. So I don't think we should just be giving it out to anyone. But I think it's probably a little too early to know now, but we're probably leaning towards the infiltrates at least being a good predictor.
Yeah, and I think it really gets to the heart of, can you make the cold tumor hot? Or are these just two completely different biologies? So it means like, what does that mean? I see you looking perplexed, right? So cold tumor means a tumor that has immune desert, there's no T cells. I mean, in the original Pembro study, right, Pembro only, no change in infiltrates, no T cells to begin with. We didn't bring anybody in. You can't unleash the immune system if there's nobody there, no audience, no effect, no clapping, right? So, my hunch is that this is very different biology. I mean, we'll find this out with the VV1 injection. We're doing the same thing. This will go to I-SPY if this really works. It'll be the first phase 1 of DCIS because invasive cancer. This is where we're about turning the paradigm on it here. But it'll be very interesting, I think. We have one more patient who I think it won't work on, but if it, I remain open. Who knows? Who knows? Questions? Yes. In the mouth. You mean a Patronus? For you Harry Potter fans, I get that.
Yeah, I would say we're mostly in the dark about that, except having that inflammation from the pro-inflammatory cytokine cells. That could potentially be what's driving that. But I think that is one of the questions is this moat a barrier? Is it protective that it's allowing the DCIS to stay where it is? Like we don't know yet. And I think it's interesting. Yeah. Thank you, Rachel.
Yeah. So we know in I-SPY 2, the addition of pembrolizumab, what predicts its success is any T cell that's PD-1 positive, and its ligand actually binds to PD-L1 within 20 microns of any PD-L1 positive cell. So if it's close, that predicts a response, which also predicts what you can do. If you can do something like prime a dendritic cell or get those dendritic cells in there. So you get this big inflammatory reaction, you're pulling those cells in there. Will that be enough? Right. So you can pull the cells in there, but you got to have the PD, but got to have the T cells in there to begin with, I think. I think it's just a completely different disease. My thought, but
You're gonna find
you're
out.
gonna find out. Yeah. All right. Oh yes, one last question.
Would it be correct to say that the receptor for you is meaning of keeping the sound of whether this works, and is that right now the movement side? That's just kind of good. Other molecular acting on BCIS.
Yeah, I mean, that's a great question. And definitely, I think one of the things is that HER2 is not like standard of care test when people get diagnosed with BCIS, but it's clearly a huge part of the story, and we're figuring out what that part of the story is. Same with Agendia, like women with BCIS don't usually get the Agendia test. They get the Oncotype test sometimes, but it's not standard of care. So it's definitely, I think it's totally relevant and super important. It's just not, it's part of distinguishing that not all BCIS is the same, and there's a lot more to the story there for sure.
Yeah, we're proposing it. Yeah, browbeating the companies to do it, but we are browbeating. Yeah. And I think that there aren't very many basal. There are not very many basal BCIS, but there are a lot of luminal Bs. I think that's, but it's, luminal A's and luminal Bs are for the active surveillance, and the kind of basal HER2 types for the other. All right. What's that? What's the chat? Who's looking at the chat?
How does that happen?
I don't, it's not up here. We're not seeing it.
Laura V has hijacked the entire presentation.
We got it.
What? I'm not seeing it. Where is it?
It's a great portfolio.
So can you read what I typed?
Okay.
Oh, wait, huh?
Oh, we have one more. I was too early.
No, it's on the slide. What, did you take the slide, Laura V?
I typed on the slide, yes. I thought this was the last presentation. I'm sorry.
Laura V is amongst us. In and amongst us.
All right.
What did you say? Did you have a question, Laura?
I didn't know this was my comment, but I was one too early. I thought we were at the end of the presentation.
No, one more. And now for something completely different.
Again.
Alex. Okay.
It's fine. I don't even see the mouse.
It's gone. It's good. Okay.
How do you control this?
All right.
Let me see. Oh, how do you make this smaller?
Oh, hold on. Where's your cursor?
Oh, there.
Oh, here. So just,
And I make it
okay.
like that.
All right, let's go.
So one important thing that I learned in this internship is it's okay to ask for help. And I know many of your mentors are busy, but if you ask them, they will be like, okay, they will make time. Maybe late at night, maybe early in the morning, but or both, yeah. But they will always make time. So hello, everyone. My name is Alex, and for my final project, I'll be showing you all a deep dive into the data regarding, well, not a deep dive, maybe a dip. Regarding the I-SPY COVID trial. This is very important since the data holds the truth
about what is working and what's not working. It also gives us the insight to people that are enrolling in the trial. In the beginning, I'll talk briefly about the I-SPY COVID trial, then show you the participating sites. Next, I'm going to show you some of the variables that the trial collects. Then I'm going to show you the results, discuss the results, and lastly, give thanks to my team members. By the end of this presentation, I hope you will learn what characteristics of people enrolled in this trial. Additionally, with the data, you all will figure out which individuals are predisposed to severe COVID. So listen closely. Okay. So the I-SPY COVID trial was opened in response to the pandemic to rapidly screen and confirm high impact treatments to reduce mortality and time on ventilators. This trial provides a place to test many drugs at once and combinations quickly to find a solution. The trial's first patient was July 31st, 2020, and now we have enrolled 3,092 patients thus far, and this continues to increase as COVID continues to wreak havoc in our communities. And on the slide, I'll just show the inclusion criteria of the trial. So this is to show you that the trial went from 7 to 8 sites to 34 sites in the course of the trial. And as you can see, the patients in the I-SPY COVID trial are enrolled from multiple different geographical locations in the US throughout the pandemic, which provides an ample opportunity to study the impact of time and geography of COVID-related outcomes. So these, instead of choosing, gathering all the data from all 34 sites, I just selected 6 because they were chosen due to the fact that they were at the start of the trial and have the most data. So now to show you a snippet of data collected in this trial. This is, mortality rates, age, comorbidity, gender at birth, race, and length of hospitalization, vaccination rates. And these are just, I'm just going to show you all these variables, but there's so much more of data that I'm not even mentioning today. So now to get started, I'm showing you a stacked bar graph that shows you a difference in sex percentages in the 6 sites. And as you can see in the red, the majority is males, while yellow is females. Next, we will review the age breakdown. Now for the age breakdown, we will see the majority for each site. It's 56 to 75. And I would say in close seconds, if you look at Columbia, we see that the second would be 75 greater, 36. But if we compared it to Yale, we see that it's a much lower percentage. And for race, we observe differences in race percentages pertaining to different geographic locations. One of the interesting thing is if you look closely to Columbia and Wake Forest, we see a high reported mixed racial percentage. And if we look at other sites, we don't really see that mixed percentage. But then again, if you look at UCSF, there's a large portion of it not being reported. So that could indicate that, hey, it could be there a population, mixed population at UCSF. Now for the vaccination rate. I split the data in 2 to see the vaccination status of before January 2021 and after February 2021. So if you look at Columbia before January 2021, we see that, vaccines weren't readily available at that time. And we could see that the majority of people enrolled in Columbia said no to vaccinations. And while there's a 50% unknown, yellow is unknown, red is yes, they're vaccinated. But after vaccines became readily available, we see the majority of people that are critically ill with COVID, majority said no vaccinations. But we did see an increase, I would say, in vaccinations, but not drastically. And like for Emory, there was no enrollment before January 21. That's why there's X. But and like UCSF, I believe there's a large proportion of unknown data. And that's due to that we added the vaccination to the CRS a little bit later. So that's why some of it is unknown and some of other sites. But if you look at Yale, we see before Jan 2021 that we see that majority of people are unknown, but after the vaccines became readily available, 81% said no vaccine, no vaccinations. So now to recap. So we learned so far that the majority of people enrolled in this trial are males. A possible explanation could be the genetic susceptibility. Sorry, since specific DNA polymorphisms were shown in ACE2 and TMPRSS2 were found to have different genetic vulnerability to COVID-19, as well as including those with cancer and high-risk group of male patients. Another is that majority of people in this trial are 56 to 75. A possible explanation could be that people's immune system weakened with age, making it more susceptible for severe COVID and also comorbidities. And then we also saw the majority of, as these vaccines became readily available, people chose not to be vaccinated. So it could just be, bias against vaccines, which put people at risk. And now here I show, back to the data, here I show the length of hospitalization, and it varies through each site in the graph. And then also, I also included the number of deaths, their proportion. And you can see it's not like it's different, it's random, I would say. And then length of hospitalization is also different. So the next slide, I just provided an average, and now it's more similar if we get the average of the length of hospitalizations. So I also got the BMI of all the 6 sites, and I got the medium and the average. And right away, we can see that each site is either overweight or severely obese, close to that. And also we saw that mortality rate is different. So if we remember in the comorbidities, Emory had none of the above comorbidities, which kind of supports that the low mortality rate at 9.4%, while Columbia had 41.3%, which can indicate that they're a much sicker population. So to recap, so the majority of people enrolled have hypertension, diabetes. We saw that in the comorbidities. And a possible hypothesis is that in diabetics, type 1, type 2, and hypertension, ACE2 is upregulated. So this will facilitate a much easier or severe infection with COVID-19. And we also found out the length of days vary. This could be due that it's just a sample bucket. People are more sicker that are being enrolled in these sites. And there was a high frequency of overweight and obese patients. And that the possible explanation is that obesity causes impaired immunity, chronic inflammation, and blood that's prone to clot, and all can worsen COVID-19. And also the ventilation characteristics are different in a patient with a high BMI. So, like I said, the data unveils the truth. So the first 6 sites, we saw a pattern in the data, and it allows us to see what characteristics are common that predispose us to get severe COVID. And these are being a male, older than 56, overweight and obese, hypertension or diabetes, and not being vaccinated. However, there was a fraction of patients in our study that had neither of these characteristics and died, and that was 1%. So for our next steps is basically reviewing more of the data, complete the analysis of the entire data set to discover more trends, and publishing several papers with the team. And also explore interventions that would be effective specifically in the setting of comorbidities associated with death with COVID-19. Let's see, go back. So to conclude the presentation, the clinical data collected has expanded our knowledge of the COVID-19 pandemic, and our goal are working toward our goal to prevent future cases. And I would like to acknowledge my team, and thank you so much.
So one of the comments this morning on the COVID team from Sarah Old, the Emory PI, what was her comment about why she thought her death rates were lower?
Because they were enrolled because they were enrolled when vaccinations were readily available to the public. So that's why I could explain the low mortality as well, because the other sites were enrolled, July 31st, 2020, where they're not readily available, which could indicate a higher mortality rate.
And also change in the variants, as you well know, what happens with those variants?
So the change of the variants, we usually have a variant each month, and it's more contagious. And we see a definitely increase of COVID cases as,
But not as sick.
but not as sick as before.
Yeah. So it's really quite interesting that the variants are changing and they're getting less. They're more contagious and less life-threatening, even for the people who are unvaccinated. That's really, yeah. What is she doing? She's the gremlin in the, but Laura is telling hooray to everybody, which is also great. Okay, last question for Alex. What did she put up there? Awesome. Yes, in the back.
So we do, but we added it much later in the clinical trial. So as we continue the trial, it'll be really interesting to explore that data and see at different sites what's the difference, and we could see probably the lower socioeconomic status would indicate maybe more, be more critically ill, less access to healthcare, or it would be nice to see the including.
Yeah, another thing that came up is mortality probably had to do with surge. At the beginning, when New York was overwhelmed, people were out there working. They had patients in the cafeteria and ICU beds, and people were dying because they were actually tension. Literally. So being in a surge is not good. So there are lots of things. And the other thing about Columbia, what was the one thing that was different about Columbia? Age. With the highest proportion of people.
The highest proportion of people were
over 75.
Over 75.
Over 75, yeah. So it's biggest risk. Anyway, so it's common things are common. It's just the RDS is tough. And I don't think people realize that, people die of flu. There's about 25 to 40,000 people a year who died of flu. About the close number of people who died of flu. Yeah. But nobody thinks about it. It's like you see a case report of 17-year-old dying of influenza, and they're like, "Well, how did that happen?" Well, that's so originally, so it was 100 times more common COVID compared to influenza, and we're getting close to down to the rate of influenza. Okay, well, what a fantastic job, everybody. I'm gonna let all of you go play, except for the next 20 minutes for Nikki and Christian and all the people doing DCI abstracts that are due in a week. We're just going to talk to Joe for like 15 minutes. Yeah. Okay, we're going to stop.